Welcome to Nightshift Horror. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin. The fluorescent light above my desk had been flickering for 3 weeks, casting intermittent shadows across the intake forms that never seemed to end. I'd grown accustomed to its irregular rhythm, 2 seconds of steady light, then a brief flutter that made the text dance before settling back into clarity. It was 11:47 p.m. on a Tuesday, and I was processing my third admission of the evening shift when everything changed. My name is Sarah Mitchell, and I've worked as an intake coordinator at Millbrook Psychiatric Hospital for 4 years. The job requires precision, verify insurance, complete the standardized psychiatric evaluation form, photograph the patient for their file, assign a room number, and ensure all documentation reaches the attending physician within 2 hours. I'd perfected this routine through nearly 1,500 admissions. Each patient receives the same careful attention, the same systematic processing that transforms them from a person in crisis into a case number with a treatment plan. The admission office sits at the end of a long corridor painted institutional green, separated from the main hospital by 2 sets of security doors. My desk faces a single window that looks out onto the parking lot, though at night it mostly reflects my own image, a tired woman in her 30s with brown hair pulled back in a practical bun. The only sounds are the hum of the computer, the occasional footstep in the distant hallway, and that persistent fluorescent flicker. Patient intake follows a predictable pattern. Security escorts arrive with individuals in various states of distress, confusion, or catatonic withdrawal. I speak in measured tones, explaining procedures, asking for basic information while trained staff ensure everyone remains calm. Most patients are cooperative. Psychiatric crisis often leaves people exhausted and compliant. The paperwork tells their stories in clinical shorthand, presenting symptoms, previous hospitalizations, emergency contact information, insurance verification numbers. But at 11:47 p.m., something shifted in that familiar routine. The security escort brought in a woman approximately my age. Medium height, brown hair disheveled but recently washed. She wore civilian clothes, jeans, and a green sweater that looked expensive but wrinkled, as if she'd been wearing them for several days. Her demeanor was calm, almost eerily composed for someone being admitted to a psychiatric facility. She sat across from my desk and folded her hands in her lap, waiting. "I need to complete your intake assessment," I said, pulling a fresh form from the drawer. "Can you state your full name for me?" "Sarah Elizabeth Mitchell," she replied without hesitation. My pen stopped moving. I looked up at her face, really looked, and felt something cold settle in my stomach. The resemblance was remarkable, though I told myself it was coincidence. Sarah is a common name. Mitchell isn't unusual either. Date of birth? March 15th, 1989. My birth date. Exactly. I continued with the questions, my handwriting becoming less steady with each response. Address. She provided my apartment complex. Unit number 1 digit off from mine. Emergency contact. She named my sister Rebecca, provided the correct phone number. Insurance. The same company that covered me through the hospital's employee plan. Previous psychiatric hospitalizations? I asked, though my voice sounded distant to my own ears. None that I remember, she said, tilting her head slightly, though I feel like I've been through this process before. Haven't we met? I completed the form mechanically, muscle memory guiding me through questions about substance use, current medications, and presenting symptoms. She described experiencing déjà vu, feeling trapped in repetitive patterns and growing confusion about her identity and role at work. Standard symptoms for acute stress reaction, though her calm delivery made them sound more like observations than complaints. The photograph was routine. I'd taken thousands. She looked directly into the camera with an expression I couldn't quite place. Not fear, not confusion, but something like recognition mixed with resignation. I printed the image and attached it to her file, then entered her information into the hospital database. The computer paused longer than usual during the search, the screen flickering in sync with the overhead light. When it finally loaded, my breath caught. The system showed previous admissions for Sarah Elizabeth Mitchell dating back 7 years. Same birth date, same address, same emergency contact. The photographs showed her face growing progressively more gaunt with each admission, but unmistakably the same person now sitting across from my desk. There seems to be some confusion, I said, scrolling through the records. The system shows multiple previous admissions. She leaned forward, studying my computer screen with professional interest. What do the notes say about my condition? I read from the most recent entry, dated 6 months ago. Patient presence with acute delusional disorder, specifically the belief that she works as an intake coordinator at this facility. Demonstrates detailed knowledge of hospital procedures and layouts, likely obtained during previous admissions. Responds well to antipsychotic medication but shows pattern of relapse and readmission. My hands were shaking now. I scrolled to earlier entries, finding similar notes spanning years. Each admission noted her persistent delusion about being a hospital employee, her detailed knowledge of intake procedures, her calm demeanor during processing. The attending physician's notes grew increasingly concerned across multiple stays. Patient's delusion appears to be deepening. She can recite hospital policies verbatim and seems to remember details about other patients and staff members that suggest either remarkable observational skills or prolonged institutional exposure. I need to verify. Something, I said, opening my desk drawer where I kept a small mirror to check my appearance before meeting with families. I held it up next to the patient's intake photograph. The resemblance wasn't just remarkable, it was identical. Same facial structure, same eye color, even the same small scar above the left eyebrow from a childhood accident I'd never told anyone about. You work here, she said, not asking but stating a fact. You've processed my admission before. I pulled up my own employee record on a separate screen. Hired 4 years ago, no disciplinary actions, exemplary performance reviews. But as I scrolled through my work history, I found gaps I'd never noticed. Weeks marked as medical leave that I couldn't remember taking. Logged hours during periods when I was supposedly absent. Supervisor notes about my improving stability following medication adjustments I'd never received. The intake form lay between us, completed in my handwriting but describing a patient whose life mirrored mine exactly. I looked at the signature line where I'd signed my name as the intake coordinator, then at the patient information section where she'd provided identical details. 2 Sarah Mitchells, same birth date, same history, sitting in the same office where one processed the other's admission to a psychiatric facility. The paperwork needs to be filed, she said gently, like she was reminding me of a forgotten task. Room assignment, physician notification, medication orders. You know the routine. I did know the routine. I'd performed it 1,500 times, including, I realized with growing horror, multiple times for the woman sitting across from my desk. The computer showed her assigned to room 237, the same room number listed on my employee badge as my emergency contact location. The attending physician was Dr. Harrison, whose name appeared on medical leave forms in my personnel file. As I completed the final sections of her intake form, my handwriting began to change, becoming less controlled, more erratic. The fluorescent light flickered faster now, and in its intermittent darkness, I could see my reflection in the window behind her, sitting in a patient chair, wearing the same green sweater, waiting to be processed. Some admissions never end. They just cycle through different perspectives on the same truth. The taste of copper pennies filled my mouth as I stared at the 13th bed that shouldn't exist. It occupied the corner where the cleaning supply closet had been for the past 6 years of my employment at Riverside Psychiatric Hospital. The bed was identical to the others. White metal frame, regulation mattress, pale blue blanket folded with military precision. But something about its presence made my vision blur at the edges. My name is David Carmichael, and I've worked the night shift in Ward C since 2018. High-security psychiatric units require specific protocols, medication distribution at midnight, patient safety checks every 15 minutes, detailed logging of all observations and interventions. 12 patients, 12 beds, 12 sets of charts hanging from the footrails. I know this ward like my own heartbeat. Every creak in the floorboards, every shadow cast by the emergency lighting, every sound the old building makes as it settles through the night hours. Ward C houses our most challenging cases, individuals with treatment-resistant psychotic disorders, patients with histories of violence, those requiring constant observation for self-harm behaviors. Room assignments never change without extensive documentation and administrative approval. Bed numbers are painted on the wall above each frame in permanent black stencil. The layout has been identical since the ward's renovation in 2015, 12 beds, always 12. But tonight, as I began my 11 p.m. shift, I counted 13. The additional bed sat in the northwest corner where the supply closet should be. I walked toward it, my footsteps echoing strangely in the quiet corridor. The patient lying there was covered completely by the standard issue blanket, only the top of their head visible, dark hair, average build, breathing rhythmically in deep sleep. The chart hanging from the bed's footrail was filled out in handwriting I didn't recognize, though the clinical observations were thorough and professional. I checked my master key ring. It still included a key for the supply closet, marked with blue tape and labeled SCC3 in my own handwriting. But when I tried that key on the supply closet door, it didn't exist. The wall was seamless, painted the same institutional beige as the rest of the ward, showing no signs of recent construction or modification. My logbook lay open on the nurse's station counter, pages filled with 6 years of nightly entries in my careful handwriting. I flipped to the previous night's record. Ward C census, 13 patients. All medications administered without incident. Patient in bed 13 continues stable sleep pattern. Minimal REM activity observed. The entry was detailed and professional, describing routine checks on 13 patients, including notes about the occupant of the corner bed. But I remembered writing about 12 patients. I was certain. I pulled the previous week's logs from the filing cabinet. Every entry documented 13 patients, 13 medication administrations, 13 safety checks. My handwriting described interactions with the 13th patient, a cooperative individual who rarely spoke but responded appropriately to instructions. According to my own notes, this person had been a model patient for months, requiring minimal intervention, sleeping peacefully through most shifts. The hospital's architectural plans were kept in the night supervisor's office. I used my master key to access the filing cabinet, spreading the Ward C blueprints across the desk. The drawings showed 13 patient rooms arranged around a central nursing station. Room dimensions, electrical specifications, plumbing layouts, all configured for 13 beds. The corner room where I remembered the supply closet was labeled patient room, 13 with detailed annotations about electrical requirements for a hospital bed and monitoring equipment. My hands shook as I compared the blueprints to my memory. Every practical detail of my work experience told me Ward C had 12 beds, but every piece of documentation proved otherwise. I returned to the ward and stood at the foot of bed 13, studying the sleeping patient. The chart showed vitals recorded every 4 hours, temperature, blood pressure, respiratory rate, all within normal ranges. Medication schedule listed standard antipsychotics and mood stabilizers, administered without difficulty. The patient's name was printed at the top of the chart in block letters. David Carmichael, my name. My exact name. I walked to the nursing station and opened my employee file, kept in the locked drawer for reference during emergencies. The photograph showed my face, but the biographical information had subtle differences. Hire date, 3 months earlier than I remembered. Previous experience included a period working as a patient care aide that I'd never held. Emergency contact listed my ex-wife, though we'd divorced 2 years before my supposed hire date. The ward's intercom crackled to life. David, this is night supervision. How's your census tonight? I pressed the response button, my voice steady despite my growing confusion. 13 patients, all stable. No incidents to report. Good to hear. Any concerns with the new assignment in room 13? No concerns, I replied automatically, though I couldn't remember receiving any information about a new patient admission. Excellent. Keep up the good work. That patient needs consistent observation. You've been doing an outstanding job these past few months. The supervisor spoke as if I'd been caring for this patient for an extended period, but I had no memory of any admission to room 13. I checked the intake paperwork filed with the chart. Admission date, 6 months ago. Admitting diagnosis, acute psychotic disorder with occupational delusions. The patient believed he worked as a night shift orderly, demonstrating detailed knowledge of hospital procedures and maintaining an elaborate fantasy about caring for psychiatric patients. The intake form included a photograph of the patient taken upon admission. The face looking back at me from the document was mine, but the expression was different. Confused, frightened, lacking the professional composure I maintained during work hours. The signature at the bottom of the form was mine as well, shaky and uncertain. Nothing like my usual confident handwriting. I walked through the ward systematically, checking each patient in beds 1 through 12. All were sleeping peacefully, their charts documenting routine care provided by the night shift orderly, me. But the handwriting in these charts was different from what I remembered producing. More clinical, more detached, noting observations about patient behaviors and responses that seemed to come from someone with extensive psychiatric training rather than my practical, on-the-job knowledge. At the nursing station, I found a staff schedule posted for the week. My name appeared in the night shift slot every day, but there was also a note, Patient D. Carmichael authorized for supervised work therapy program. Orderly duties to be performed under direct observation of licensed nursing staff. Therapeutic value, maintains connection to previous occupation, provides structured activity during nighttime wakeful periods. Work therapy. I was a patient participating in a program that allowed me to perform the job I believed I'd held for 6 years. I returned to bed 13 and looked down at the sleeping figure who shared my name. The chart showed he'd been admitted following a psychotic break triggered by work-related stress. Initial symptoms included the belief that he was responsible for caring for 12 psychiatric patients, detailed knowledge of hospital procedures he couldn't have legitimately possessed, and persistent insistence that his work environment had been altered without his knowledge. The patient's treatment plan included gradual reality orientation, medication management, and occupational therapy designed to help him process his delusional beliefs about working in a psychiatric hospital. Notes from the treating psychiatrist indicated some improvement. The patient now acknowledged the existence of 13 beds instead of insisting on 12, showed better cooperation with unit routines, and displayed more appropriate recognition of his actual role in the facility. I sat in the chair beside bed 13, watching the steady rise and fall of the patient's breathing. My breathing, the logbook entry I needed to complete, lay open on my lap, waiting for me to document another routine night shift caring for 13 patients in Ward C. Outside the windows, the sky was beginning to lighten with approaching dawn, and soon the day shift would arrive to take over patient care responsibilities. But as I prepared to write my final entry for the night, I realized I could no longer distinguish between caring for the patients and being cared for. The routine remained the same: medication schedules, safety checks, detailed documentation, but my perspective had shifted so gradually that I couldn't identify the moment when I'd moved from the nursing station to the bed, from the caregiver to the patient receiving care. Some shifts never end. They just change which side of the chart your name appears on. The leather notebook made the same soft thud against the arm of the chair every Thursday at exactly 3 p.m. Dr. Elena Vasquez had grown accustomed to that sound over 12 weeks of sessions with her most challenging patient, though she'd begun to notice unsettling patterns in their therapeutic work that defied conventional explanation. Room 7B existed in the hospital's original wing, built in 1952 and renovated only superficially since then. The space contained standard therapeutic furniture, 2 chairs positioned at comfortable angles, a small table for tissues and water, a desk where Dr. Vasquez kept session notes and treatment planning materials. No windows, no distractions, no external stimuli that might interfere with the delicate process of helping patients recover fragmented memories. The patient was a woman in her early 30s, who'd been admitted 6 months ago following what appeared to be a dissociative episode triggered by severe psychological trauma. She had no memory of her identity, background, or the events leading to her hospitalization. Hospital staff called her Jane until a more permanent solution could be determined. She presented as intelligent, articulate, and cooperative, though her complete amnesia extended to basic personal information that most people retain even during severe psychological distress. But Jane's amnesia had an unusual quality that disturbed Dr. Vasquez more with each session. Rather than the typical blank confusion or distress associated with memory loss, Jane displayed detailed knowledge about psychiatric treatment, therapeutic techniques, and hospital procedures that suggested professional training. She used clinical terminology correctly, asked sophisticated questions about her treatment plan, and demonstrated insight into her condition that exceeded what most patients could achieve without extensive education in mental health fields. I've been thinking about our conversation last week, Jane began, settling into her usual chair and opening the leather notebook. You mentioned transference as a potential factor in my recovery process. I wanted to explore that concept further. Dr. Vasquez nodded, though she felt increasingly uncomfortable with how Jane analyzed their therapeutic relationship with professional detachment. What thoughts did you have about transference? I think I may be projecting memories of being a therapist onto our sessions, Jane replied, consulting handwritten notes in her notebook. I keep having these vivid recollections of sitting in a chair like yours, conducting therapy with a woman who couldn't remember her own name. The woman in my memories looks remarkably like you. These recursive delusions had emerged gradually. Jane described elaborate fantasies about working as a psychiatric resident, treating patients with dissociative disorders, conducting sessions in room 7B. She provided specific details about therapeutic interventions, diagnostic criteria, and treatment protocols that demonstrated either remarkable intuitive understanding or actual clinical experience. Tell me more about these memories, Dr. Vasquez said, making notes in Jane's file. What do you remember about the therapeutic work? Jane flipped through pages of detailed observations written in neat handwriting. The patient, the woman who looks like you, was admitted following what appeared to be a psychotic break. She believed she was a psychiatric resident conducting therapy sessions, but she was actually a patient with severe delusional disorder. I worked with her for months, trying to help her distinguish between reality and her elaborate professional fantasies. Dr. Vasquez felt cold spreading through her chest. Jane's description matched elements of their therapeutic relationship with disturbing accuracy, but with roles reversed. According to Jane's memories, she was the doctor treating a delusional patient who believed she was Dr. Vasquez. In these memories, what was your patient's name? Dr. Vasquez asked, though she dreaded the answer. Elena Vasquez, Jane replied without hesitation. Second-year psychiatric resident treating her first case of dissociative amnesia. She was convinced she was the doctor, but her medical knowledge contained gaps and inconsistencies that revealed her actual status as a patient. Dr. Vasquez reviewed her own notes from previous sessions. Her handwriting documented Jane's progressive recovery of memories about her supposed career as a therapist. But now she noticed details in her notes that she didn't remember writing. Observations about her own behavior during sessions, concerns about her medical knowledge, questions about her professional credentials that seemed directed at herself rather than her patient. Jane, I need to verify something about your background, Dr. Vasquez said, reaching for the intake file. The admission paperwork should contain basic information about your identity. Of course, Jane replied. Though I should mention that intake paperwork can be unreliable when patients are admitted during acute psychotic episodes. They sometimes provide false information about their professional credentials. Dr. Vasquez opened Jane's file and found documents that made no sense. The intake form listed the patient's occupation as psychiatric resident and included detailed medical history, education credentials, and professional references. But the photograph attached to the file showed Dr. Vasquez herself, wearing patient clothing and looking confused and distressed. There seems to be an error in your file, Dr. Vasquez said, her voice becoming less steady. The photograph doesn't match. Jane leaned forward to examine the documents, then consulted her notebook again. I remember now. When you were admitted, you insisted you were a doctor. You provided detailed information about your medical training, but the credentials couldn't be verified. The hospital staff was patient with your delusions, understanding that acute psychological trauma can create elaborate false identities. Dr. Vasquez pulled her own personnel file from the desk drawer, needing to confirm her employment status and professional credentials. But the file she found contained different information than she expected. Hire date, 6 months ago, the same date as Jane's admission. Position, patient, not staff member. Diagnosis, delusional disorder with grandiose features. Specifically the belief that she was a medical professional qualified to treat psychiatric patients. The hospital has been very accommodating, Jane continued, reading from her notes. They allow you to conduct supervised therapy sessions as part of your treatment program. The therapeutic value comes from gradually helping you recognize the difference between your professional fantasies and reality. Room 7B is actually configured as both a therapy space and a controlled environment for patients with occupational delusions. Dr. Vasquez looked around room 7B with new awareness. The furniture arrangement allowed for observation from multiple angles. The desk where she kept her files was positioned so that someone outside the room could monitor her activities. What she'd interpreted as therapeutic privacy was actually supervised patient interaction designed to support her treatment. "Show me your notebook," Dr. Vasquez said. Though her authority to make such requests suddenly felt questionable, Jane handed over the leather journal willingly. The pages contained detailed session notes written in professional format, documenting 12 weeks of therapeutic work with a patient identified as E. Vasquez. The notes described progressive treatment of delusional disorder, including the patient's gradual acceptance of reality and improvement in insight regarding her condition. According to Jane's documentation, Dr. Vasquez had initially presented with complete conviction that she was a psychiatric resident qualified to treat patients with dissociative amnesia. Treatment involved allowing her to conduct supervised sessions while gradually introducing reality testing and medication management. The most recent notes indicated significant improvement. The patient was beginning to question her professional identity and showing signs of recognizing her actual status. "You've made remarkable progress," Jane said gently, taking back her notebook. "When you first arrived, you couldn't accept that your medical knowledge came from television shows, internet research, and overheard conversations during previous hospitalizations. Now you're able to consider alternative explanations for your experiences." Dr. Vasquez stared at her hands, noting that they trembled slightly, a side effect she'd attributed to stress, but which now seemed consistent with antipsychotic medication. Her memories of medical school, residency training, and professional development felt detailed and authentic. But Jane's notes raised disturbing questions about their reliability. "What happens next in my treatment?" Dr. Vasquez asked, the question emerging before she could consider its implications. "We continue working together," Jane replied, making a final note in her session documentation. "Recovery from delusional disorder takes time, especially when the delusions are as elaborate and professionally detailed as yours. But you're showing excellent insight development and medication compliance." As Jane prepared to leave, Dr. Vasquez realized she couldn't determine which of them was the patient and which was the therapist. The therapeutic relationship had become so recursive that both perspectives seemed equally valid and equally impossible. Some sessions never end. They just reveal which chair you were sitting in all along. The pill counter clicked rhythmically as I sorted tonight's medication orders in the basement pharmacy of Clearwater Psychiatric Hospital. 27 prescriptions for the night shift, each requiring verification against patient records, dosage calculation, and duplicate documentation in both electronic and paper logs. I had perfected this routine through 18 months of employment, and my accuracy rate remained flawless. My name is Rachel Foster, and precision defines my professional identity. Pharmaceutical work allows no margin for error. Wrong medications, incorrect dosages, or missed interactions can prove fatal in psychiatric settings where patients often take multiple psychoactive drugs. Every pill must be counted twice, every prescription verified against current patient records, every dispensation logged with timestamp and technician identification. The pharmacy operates on absolute accountability, but over the past 3 nights, my carefully maintained system had begun revealing impossible discrepancies. The first anomaly appeared Monday evening, a prescription for risperidone ordered for Margaret Chen. Room 204, standard dosage, standard frequency, signed by Dr. Williams with proper DEA number. But when I checked the patient census, Margaret Chen had been discharged 6 weeks ago following successful treatment. Her room was currently occupied by a different patient entirely. I called the nurses' station to clarify. "This is Rachel in pharmacy. I have a prescription for Margaret Chen in 204, but my records show she was discharged last month." "Chen." "We don't have anyone by that name on the floor," the nurse replied. "Room 204 is Thomas Mitchell, admitted 3 days ago." I pulled Margaret Chen's complete file from the archived records. Admission date, 14 months ago. Discharge date, 42 days ago. Final notes indicated successful treatment and stable outpatient transition. But the prescription in front of me was dated today, written in Dr. Williams' characteristic handwriting, specifying medications for a patient who no longer resided in the facility. Tuesday night brought more irregularities. 5 prescriptions for patients I couldn't locate in current records. Individuals discharged months ago, transferred to other facilities, or never admitted according to hospital databases. Each prescription was professionally written, properly formatted, signed by attending physicians with correct credentials. But the patients didn't exist in our current census. I began maintaining a separate log of these phantom prescriptions, documenting each discrepancy for review with the pharmacy supervisor. Patient names, medication orders, prescribing physicians. Room assignments, all professionally documented, but referring to individuals who weren't currently receiving treatment at Clearwater. Wednesday night, the pattern intensified. 11 prescriptions for non-existent patients, including several signed by Dr. Harrison, who'd left Clearwater 3 years ago to work at a facility in another state. I verified his departure through HR records. Final employment date, forwarding address, professional references for his new position. Yet his signature appeared on prescriptions dated this week, written for patients in rooms that housed different individuals. The most disturbing discovery came near the end of Wednesday's shift. Among the phantom prescriptions, I found an order for Rachel Foster, room B12. My name, written in Dr. Harrison's familiar handwriting, prescribing a combination of mood stabilizers and antipsychotic medications typically used for patients with severe psychiatric conditions. Room B12 was in the basement level, near the pharmacy. I'd never been in that room, but my master key provided access to all patient areas for emergency medication delivery. The room was occupied by a woman approximately my age with brown hair pulled back in a practical ponytail. She wore patient clothing and sat quietly on the edge of the bed, hands folded in her lap. "Rachel," I said from the doorway, "I have your evening medications." She looked up with an expression of confused recognition. "I don't understand why I need medication. I work in the pharmacy. I'm supposed to be dispensing pills, not taking them." I checked the chart hanging from her bed rail. Patient name, Rachel Foster. Admission date 6 months ago. Diagnosis, acute psychotic disorder with occupational delusions. The chart documented detailed treatment notes describing a patient who believed she worked as a pharmacy technician, demonstrating extensive knowledge of medication management and pharmaceutical procedures that suggested either professional training or prolonged exposure to hospital operations. "The medications help with your symptoms," I explained, though the conversation felt surreal. "Dr. Harrison prescribed them specifically for your condition." "Dr. Harrison doesn't work here anymore," she replied with certainty. "He left 3 years ago. I remember processing the paperwork when his privileges were terminated." Her knowledge was accurate but impossible. Patient records showed she'd been admitted months after Dr. Harrison's departure, yet she possessed detailed information about his employment history. I administered her medications according to the prescription, watching as she swallowed each pill with practiced compliance. Back in the pharmacy, I reviewed my own personnel file to confirm my employment status and credentials, but the file I found contained information that didn't match my memory. Hire date, 6 months ago, coinciding with the admission date for the patient in room B12. Position, patient, not pharmacy technician. Educational background, no pharmaceutical training, though extensive self-taught knowledge acquired during hospitalization. My professional certifications were missing from the file. Instead, I found treatment plans documenting occupational therapy designed to help me process delusional beliefs about working in pharmaceutical services. Notes from my treating psychiatrist described the therapeutic value of allowing me to perform supervised medication preparation activities, gradually introducing reality testing while maintaining engagement with familiar routines. I searched the pharmacy for evidence of my legitimate employment, time cards, training certificates, performance evaluations. But the documentation I found suggested I was a patient participant in a work therapy program, permitted to assist with medication preparation under direct supervision of licensed pharmacy staff. My key card, which I'd believed provided access for medication delivery, was actually programmed to limit my movement to approved areas during supervised activities. The phantom prescriptions began to make sense as I reviewed them with new understanding. They were real prescriptions for real patients, but the patients existed in a different time frame than my current perception. Margaret Chen, Thomas Mitchell, the other names I'd been unable to locate, they were patients I'd served during my actual employment, before the psychological break that led to my admission. My detailed knowledge of pharmaceutical procedures, my obsessive precision with medication preparation, my ability to identify drug interactions and dosage errors, these skills had been acquired during legitimate employment at Clearwater, before the incident that transformed me from pharmacy technician to psychiatric patient. The basement pharmacy where I spent my nights wasn't my workplace. It was my therapy space, designed to help me maintain connection to my previous occupation while processing the trauma that had ended my career. The medications I believed I was dispensing to other patients were actually part of my own treatment plan, administered through role-playing scenarios that allowed me to maintain professional identity while receiving psychiatric care. Some prescriptions never stop being filled. They just change who's taking the medication. The filing cabinet in section M7 contained a folder that shouldn't exist, filed between Malone and Marsh with mechanical precision, despite my complete certainty that I'd never processed those particular documents. The tab read, Matthews Lindicay in my own handwriting. But I had no memory of creating the file or entering the patient into our comprehensive cataloging system. My name is Linda Matthews, and I've maintained the Medical Records Archive at Westbridge Psychiatric Hospital for 8 years. The repository occupies 3 basement levels containing 47 years of patient documentation organized according to strict alphabetical and chronological protocols. Every file follows identical formatting: intake assessment, treatment notes, medication records, discharge planning, and final disposition. I personally catalog every document, cross-reference every entry, and maintain duplicate indexes that ensure no patient record can be lost or misfiled. The archive operates on absolute precision. Patient confidentiality requires that files remain secure, accessible only to authorized personnel with legitimate clinical need. I process approximately 15 requests per day: psychiatrists reviewing treatment history, nurses verifying medication protocols, administrators completing insurance documentation. Each request is logged, each file retrieved is documented, each return is verified. No document leaves the archive without my knowledge and approval, but this morning, I discovered files I'd never cataloged, organized in sections I'd never created, documenting treatments in wards that didn't exist in hospital blueprints. The Matthews file contained intake paperwork dated 3 years ago, though my employment records showed I'd worked continuously in the archive during that period. The patient photograph showed my face, but I appeared confused and distressed, wearing institutional clothing rather than the professional attire I maintained during work hours. The intake form listed my occupation as medical records clerk, but noted it as a delusion rather than actual employment. According to the documentation, Linda Matthews had been admitted following an acute psychotic break triggered by work-related stress. Initial symptoms included elaborate beliefs about maintaining a hospital archive, detailed knowledge of filing systems she couldn't have legitimately accessed, and persistent insistence that she was responsible for cataloging patient records. The treating psychiatrist noted that her delusions demonstrated remarkable internal consistency and professional accuracy, suggesting either previous exposure to medical record systems or an unusually systematic form of occupational psychosis. I pulled my own personnel file from the administrative section, needing to verify my employment status and professional credentials. But the file I found contained different information than I expected. Hire date, 3 years ago, coinciding with the patient admission date in the Matthews file. Position, patient, not employee. Supervisor, Dr. Catherine Wells, who I recognized as the psychiatrist whose signature appeared on treatment notes I'd been finding throughout the archive. The treatment plan in my file described occupational therapy designed to help me process delusional beliefs about working as a medical records clerk. Notes indicated that I'd been given supervised access to archived files as a therapeutic intervention, allowing me to maintain connection to my imagined profession while gradually introducing reality testing. The program was considered successful. I demonstrated appropriate behavior, followed institutional routines, and showed no signs of agitation or resistance to treatment. But as I read these documents, I became aware of impossible details that challenged their authenticity. The treatment notes referenced conversations with Dr. Wells that I couldn't remember, described medications I wasn't taking, and documented behaviors that didn't match my experience of working alone in the archive. The handwriting in the notes was professional and consistent. but it described a version of myself that felt foreign and disconnected from my daily experience. I began searching the archive systematically, looking for other files that might contain similar discrepancies. In Section A through C, I found dozens of patient records I'd never processed, filed with perfect accuracy in locations I couldn't remember accessing. The files described individuals with various psychiatric conditions, all treated by Dr. Wells, all documenting therapeutic programs similar to mine. One file particularly disturbed me. Peterson, James R., admitted for delusional beliefs about working as a hospital custodian. His treatment notes described occupational therapy involving supervised cleaning duties, allowing him to maintain connection to his imagined profession while receiving psychiatric care. But I remembered James Peterson. He cleaned the archive floors every Tuesday evening, spoke knowledgeably about hospital operations, and maintained professional relationships with staff members throughout the facility. According to his file, James Peterson was actually a patient who believed he was a custodian, participating in a work therapy program that provided therapeutic value through structured activities related to his delusions. The notes indicated excellent progress. He performed cleaning duties reliably, interacted appropriately with other patients and staff, and showed no signs of distress about his psychiatric condition. I found similar files for other individuals I'd considered colleagues. Sandra Chen, who delivered files to clinical departments, documented as a patient with delusions about working in medical records transport. Michael Torres, the security guard who checked credentials before allowing access to the archive, described as participating in a therapeutic program for patients with authority-related occupational fantasies. Rebecca Davis, the night shift supervisor who occasionally reviewed my work, filed as a patient whose treatment involved supervised administrative activities. Each file documented successful occupational therapy programs designed to help patients with work-related delusions maintain connections to their imagined professions while receiving psychiatric treatment. The programs were considered innovative and therapeutically valuable, allowing patients to engage in structured activities that provided meaning and routine without challenging their delusional beliefs directly. But the files raised disturbing questions about the nature of my work environment. If my colleagues were actually patients participating in therapy programs, what did that make the archive itself? I examined the hospital blueprints more carefully, paying attention to the basement levels where I spent my working hours. The architectural plans showed the basement areas designated as patient activity centers rather than medical records storage. Room assignments included occupational therapy spaces, supervised work areas, and recreational facilities designed to support various therapeutic programs. The archive I'd maintained for 8 years was actually a patient activity center configured to resemble a medical records repository, allowing multiple patients with filing-related delusions to participate in meaningful therapeutic activities. I returned to Section M7 and retrieved my own file again, reading the treatment notes with new understanding. Dr. Wells's documentation described my enthusiastic participation in the records management program, noting my attention to detail, my professional demeanor, and my apparent satisfaction with the work. The notes indicated that I'd developed an elaborate and internally consistent understanding of my role, creating detailed filing systems and maintaining accurate records of my daily activities. The most recent entries in my treatment file documented my growing awareness of discrepancies in the archive, my questions about files I didn't remember processing, and my concerns about colleagues whose employment status seemed questionable. Dr. Wells noted this as positive progress, indicating that I was beginning to develop insight into my condition and question the reality of my delusional workplace. But even as I read these explanations, I couldn't reconcile them with my lived experience of working in the archive. My knowledge of medical record management was extensive and practical, acquired through years of hands-on experience with patient files, clinical documentation, and administrative procedures. The files I'd cataloged contained real medical information about actual patients receiving treatment at Westbridge Psychiatric Hospital. I walked through the archive one more time, examining the vast collection of patient records I'd maintained with obsessive precision. Row after row of files, organized alphabetically and chronologically, cross-referenced and indexed according to professional standards I'd learned through formal training and practical application. The scope of the collection was enormous, representing decades of psychiatric treatment and thousands of individual cases. If this was all an elaborate therapeutic program designed to support my occupational delusions, it represented an incredible investment of resources and professional commitment. The files contained authentic medical information, the organizational systems followed legitimate archival standards, and my daily work contributed real value to hospital operations. Or perhaps that was exactly the point of the program, to provide therapeutic value through meaningful work that felt authentic and important, allowing patients with occupational delusions to maintain professional identity while receiving treatment for underlying psychiatric conditions. As I prepared to leave the archive at the end of my shift, I realized I could no longer distinguish between working as a medical records clerk and participating in occupational therapy designed to help me process delusions about working as a medical records clerk. The daily routine remained identical, the work felt equally meaningful, and my professional satisfaction was unchanged regardless of the underlying reality. Some files never stop being cataloged. They just change which side of the record you appear on. My watch read 11:47 p.m. as I completed the first circuit of my patrol route. But according to the wall clock in the main lobby, only 11 minutes had passed since I'd started at 11:30. The discrepancy was small enough to dismiss as a minor timing error, but it troubled me because precision had defined my work at Northgate Psychiatric Hospital for 6 years without a single irregularity. My name is Robert Chen, and I maintain security for the night shift at Northgate, patrolling empty corridors from 11 p.m. to 7 a.m. with mechanical consistency. The route never varies. Main lobby, security desk, administrative wing, patient wards A through D, back stairwells, maintenance areas, then return to the starting point. 30 minutes per complete circuit, 16 circuits per shift, documented in the security log with timestamp and observations. The routine provides comfort in its predictability and purpose in its precision. Night security in a psychiatric hospital requires specific protocols. Patient safety is paramount. Doors must remain locked. Monitoring equipment must function properly. Emergency exits must stay clear and accessible. I carry keys to every area of the facility, radio communication with the nursing supervisor, and authority to call additional personnel if situations require intervention. Most nights pass without incident. The building settles into quiet routines, and my footsteps echo through corridors where patients sleep under careful medical supervision. But tonight, time seemed to be operating according to different rules than those I'd learned through 6 years of identical shifts. My second patrol circuit began at what my watch indicated was 12:20 a.m., but the lobby clock showed 11:45 p.m. The discrepancy had increased to 35 minutes, suggesting either my watch had malfunctioned or the building's electrical system was affecting the wall clocks throughout the facility. I noted the observation in my security log, planning to report the timing issue to maintenance during the next business day. As I walked through the administrative wing, I encountered another security guard performing identical patrol duties. He wore the same uniform, carried the same equipment, and followed the same route I'd been walking. We nodded to each other professionally as we passed in the corridor, though I was surprised that management had assigned a second guard without informing me of the schedule change. "Quiet night," he said as we met near the elevator bank. "Very quiet," I agreed, noting that his voice sounded remarkably similar to mine. "I don't think we've worked together before." "6 years on this shift," he replied. "Same route every night. Lobby, administrative, patient wards, backstairs, maintenance areas. 30 minutes per circuit." I paused, studying his face more carefully. The resemblance was striking. Same height, same build, same facial features. Even his mannerisms matched mine. The way he held his radio, the cadence of his walk, the professional demeanor he maintained while speaking with colleagues. "What time do you have?" I asked, checking my watch again. 2:55 a.m., he replied, though my watch showed 1:20 a.m. and the nearby wall clock indicated 12:15 a.m. We were experiencing the same timing discrepancies but measuring different durations. His patrol schedule seemed to be running 25 minutes behind mine, while both of us were apparently ahead of the building's official timepieces. I made additional notes in my security log, documenting the unusual timing issues and the presence of the second guard. During my third circuit, I encountered the same guard again, but this time he was 20 minutes ahead of me on the route. I found him in the patient ward area, conducting the same security checks I'd been performing. When I reached the location where I'd seen him, he was gone, but I could hear his footsteps echoing from the administrative wing behind me. "Security to nursing station," I called on my radio. "Can you confirm how many guards are assigned to tonight's shift?" "Just you, Robert," came the reply from the nursing supervisor. Same as always. "Is there a problem?" I looked around the empty corridor, seeing no sign of the other guard but still hearing footsteps that seemed to follow the same patrol pattern I maintained. "No problem. Just checking protocols." My fourth circuit took what felt like 45 minutes, according to my subjective experience, though my watch advanced only 20 minutes and the wall clocks showed a 15-minute progression. The temporal discrepancies were becoming more pronounced, and I was beginning to question whether the timing issues represented equipment malfunction or something more disturbing. About my own perception of reality, I found the security office and reviewed the duty roster for the night shift. Only one guard was scheduled, Robert Chen, 11 p.m. to 7 a.m., same assignment I'd held for 6 years. But the logbook contained entries in my handwriting documenting interactions with other security personnel, observations about coordination between multiple guards, and notes about timing discrepancies that suggested ongoing awareness of the temporal anomalies. The entries spanned several weeks, describing increasingly complex patrol schedules involving multiple versions of myself maintaining security coverage throughout the hospital. According to my own documentation, I'd been encountering other guards regularly, coordinating our activities to ensure complete facility coverage without overlap or security gaps, but I had no memory of writing these entries or experiencing the interactions they described. I reviewed security camera footage from earlier in the shift, expecting to see evidence of the second guard I'd encountered multiple times. The recordings showed me walking through corridors alone, conducting routine security checks, following my standard patrol pattern. But the timestamps on the footage didn't correspond to my watch or the wall clocks, and the duration of my activities varied significantly between different camera angles. In some recordings, I appeared to complete entire circuits in 15 minutes. In others, the same patrol took over an hour. The footage showed me having conversations with individuals who weren't visible in the frame, responding to voices I couldn't hear, and coordinating activities with people who cast no shadows on the security monitors. I returned to the main lobby and stood in front of the central clock, watching its progression while monitoring my own timepiece. The wall clock advanced at a steady rate, marking each minute with mechanical precision. But my watch seemed to accelerate and decelerate unpredictably, sometimes racing ahead of the official time and sometimes falling behind. As I stood there, another security guard entered the lobby from the administrative wing. Same uniform, same appearance, same professional demeanor. He approached the security desk and began making entries in the logbook, documenting his patrol observations in handwriting that matched mine exactly. "How's your shift going?" I asked. "Routine night," he replied without looking up. "Though I've been having timing issues. My watch doesn't seem to match the building clocks." "Same problem here," I said. "Management should probably have maintenance check the electrical systems." He nodded and continued writing in the logbook, making notes about temporal discrepancies and coordination with other security personnel. When he finished, he looked up at me with an expression of mild confusion. "Haven't we had this conversation before?" he asked. "I don't think so," I replied, though the interaction did feel familiar in a way I couldn't identify. "Maybe it was with one of the other guards," he said, checking his watch against the wall clock. "There seem to be several of us working tonight." As he left to continue his patrol, I realized that I could no longer determine which security guard was the original and which were the temporal duplicates. Each of us followed identical routes, maintained identical professional standards, and experienced identical timing discrepancies. We were all equally real and equally impossible, existing in slightly different temporal frameworks that allowed us to encounter each other without paradox. The radio crackled with a call from the nursing supervisor. "Robert, can you respond to Ward C? We have a patient asking about the security guard who's been walking past her room every 10 minutes for the past hour." "On my way," I replied, though I realized that multiple versions of that response were probably being transmitted simultaneously from different points along my patrol route. Some shifts never end. They just repeat with different timing while you try to figure out which version of yourself is supposed to go home in the morning. The patient's pupils contracted normally under pen light examination. His breathing remained deep and regular, and the consciousness monitor showed flat lines indicating complete anesthetic depth. Standard protocol had been followed precisely, pre-medication administered 15 minutes prior, intravenous sedation delivered in calculated doses, muscle relaxants given to prevent physical trauma during seizure activity. He was ready for electroconvulsive therapy, unconscious and unaware, exactly as he should be. My name is Dr. Margaret Ellis, and I've administered anesthesia for psychiatric procedures at Riverside Treatment Center for 12 years. ECT requires specific protocols. Patients must be completely unconscious during electrical stimulation. Muscle activity must be suppressed to prevent injury, and recovery must be carefully monitored to ensure safe emergence from anesthesia. I've performed this procedure over 800 times without a single complication or awareness event. But as Dr. Richardson applied the electrodes to the patient's temples and prepared to deliver the therapeutic current, something went wrong in a way that defied medical explanation. The patient's eyes opened, not the reflexive flutter that sometimes occurs during light anesthesia, but deliberate, conscious awareness. His gaze fixed on mine with complete clarity and recognition, though every monitoring device confirmed he remained in deep anesthetic unconsciousness. Pulse oximetry, blood pressure, consciousness depth, neurological activity, all readings indicated appropriate sedation levels for the procedure. "You've done this to me before," he said, though his vocal cords should have been paralyzed by muscle relaxants. I checked the anesthesia machine immediately, verifying drug delivery, dosage calculations, and equipment function. Everything operated within normal parameters. The patient had received appropriate medications in correct amounts, administered through patent intravenous access, confirmed by standard monitoring protocols. "The patient appears to be experiencing awareness," I said to Dr. Richardson, though the consciousness monitor continued showing unconscious patterns. "Readings look normal from here," Dr. Richardson replied, reviewing the neurological displays. "Heart rate stable, blood pressure appropriate. No signs of consciousness or distress." But the patient continued speaking, his voice calm and conversational despite the impossibility of vocalization under current anesthetic conditions. "This is my 17th session with you, Dr. Ellis. Each time, you express concern about my apparent awareness, but the monitors always indicate appropriate unconsciousness. I reviewed my records for this patient, David Martinez, age 34, treatment-resistant depression, scheduled for his first series of ECT treatments. According to documentation, this was his initial session, with no previous exposure to electroconvulsive therapy. But he spoke with detailed knowledge of our procedures, my protocols, and specific conversations we'd never had. "David, can you tell me your name and where you are?" I asked, conducting a standard awareness assessment. "David Martinez, Riverside Treatment Center, ECT Suite 2B. He replied immediately. "You're Dr. Ellis, anesthesiologist. Dr. Richardson is the psychiatrist administering treatment. This is my 17th session, though your records will show it's my first." I pulled his complete medical file, searching for evidence of previous ECT treatments. The documentation showed initial psychiatric evaluation, medication trials, treatment planning, and approval for electroconvulsive therapy as a new intervention. No previous sessions were recorded, no anesthesia records existed, no recovery notes had been filed. But as I reviewed the file more carefully, I found inconsistencies that disturbed me. Handwritten notes in margins described patient responses to anesthesia across multiple sessions. Medication dosages had been adjusted upward over time, suggesting tolerance development through repeated exposure. My own signature appeared on anesthesia records dated throughout the past month, documenting 17 previous ECT sessions for David Martinez. "The documentation is confusing because we exist in a temporal loop," David explained, maintaining conversational tone despite theoretical unconsciousness. "Each session resets the official records, but you retain subconscious awareness of previous treatments. That's why you've been increasing my anesthesia dosages. You remember that lighter doses don't maintain unconsciousness." I checked the drug calculations again. The doses I'd administered were significantly higher than standard protocol recommended for a patient of David's size and medical history. But they matched the dosages I'd used for someone who'd developed tolerance through repeated anesthetic exposure. Somehow I'd been compensating for tolerance that shouldn't exist based on official treatment records. "Dr. Ellis, are we proceeding with treatment?" Dr. Richardson asked, though he seemed unaware of the patient's vocalization or our ongoing conversation. "The patient appears to be conscious," I repeated, noting that my concern was escalating despite normal monitoring readings. "Consciousness depth looks appropriate," Dr. Richardson replied, reviewing the same displays that indicated unconsciousness to him, but somehow failed to detect the patient's obvious awareness. David continued speaking, his words audible only to me, despite the presence of other medical personnel in the treatment room. Dr. Richardson can't hear me because his perception is limited to his role in the loop. "You're beginning to develop awareness because anesthesia creates a bridge between conscious and unconscious states." The concept was medically nonsensical, but it explained the impossible situation I was experiencing. If David and I were trapped in some form of temporal repetition, it would account for his knowledge of previous sessions, my unconscious adjustment of drug dosages, and the contradictory documentation in his medical file. "How many times have we had this conversation?" I asked. "This is the first time you've been able to hear me clearly," David replied. "Previous sessions you experienced vague uneasiness, increased my medications without understanding why, and made notes about unusual patient responses. Your growing awareness is breaking down the barriers that maintain the loop." I reviewed my personal notes from recent ECT cases, looking for evidence of the pattern David described. I found increasing references to patient awareness concerns, medication adjustments for tolerance that shouldn't exist, and general anxiety about anesthetic procedures that had previously felt routine and comfortable. My own anesthesia records showed subtle changes in technique over the past month. Higher drug doses, additional monitoring protocols, extended recovery observation periods. The modifications suggested I'd been responding to complications or concerns that weren't documented in official patient files but were influencing my clinical decision-making. "What happens if I refuse to continue the procedure?" I asked. "The session resets," David replied. "You'll find yourself preparing anesthesia for my first ECT treatment, with no memory of our conversation. The loop continues until something breaks the pattern. And if I proceed with treatment despite your apparent consciousness, the electrical current will cause seizure activity while I remain aware of the experience. You'll document it as a successful procedure with appropriate anesthesia, but you'll retain unconscious memory of my consciousness. Your anxiety about ECT will increase, and you'll make further modifications to your protocols." I faced an impossible choice: abandon a medically necessary treatment based on impossible patient consciousness, or proceed with a procedure that would cause suffering I could observe but couldn't prove to colleagues. Either decision seemed to perpetuate the cycle David described. "There is another option," David said, though his expression remained calm despite the implications. "If you document my awareness officially, describe exactly what you're experiencing, and request suspension of ECT pending investigation, it might disrupt the loop." I opened my laptop and began typing a detailed incident report. Patient demonstrated clear consciousness during ECT preparation despite appropriate anesthetic depth indicated by all monitoring equipment. Patient engaged in complex conversation, demonstrated knowledge of previous treatments not documented in medical records, and maintained awareness throughout muscle relaxation and sedation protocols. As I typed, I realized the report described an impossible medical situation that would raise questions about my competency, my equipment, and my understanding of anesthetic principles. But it also represented the first official documentation of the temporal anomaly that had been affecting my work for weeks. "Dr. Ellis, we really need to proceed or reschedule," Dr. Richardson said, checking the treatment schedule. "I'm documenting a significant anesthetic complication," I replied, continuing to type. "This patient has demonstrated awareness despite appropriate sedation, and I cannot proceed with ECT under these conditions." The incident report grew longer as I described every detail of David's consciousness, our conversation, and the contradictory monitoring readings. With each sentence, I felt the temporal loop straining against documentation that didn't fit its pattern. When I finished the report and submitted it to the hospital's quality assurance system, David smiled for the first time during our interaction. "Thank you," he said. "Now we can both wake up." The treatment room began to fade around the edges, and I realized I'd been documenting the first successful disruption of a cycle that had trapped us both in repetitive medical procedures that existed outside normal time. Some anesthesia never wears off. It just changes which patient is dreaming the surgery. The watercolor portrait emerged from behind a landscape painting I'd filed just yesterday, depicting a woman in institutional clothing with hollow eyes and trembling hands reaching toward an unseen observer. The artistic technique was sophisticated. Controlled brush strokes, professional understanding of color theory, anatomical accuracy that suggested formal training. But the subject matter disturbed me because the woman in the painting resembled me with unmistakable precision. My name is Catherine Wells, and I conduct art therapy sessions at Millfield Psychiatric Hospital, helping patients process trauma through creative expression. The recreation room contains easels, paint supplies, clay for sculpture work, and a variety of materials that allow individuals to communicate experiences they cannot verbalize. I maintain portfolios for each patient, documenting artistic development and therapeutic insights that emerge through their creative work. Art therapy provides unique access to unconscious material that traditional talk therapy cannot reach. Patients often create images that reveal suppressed memories, hidden fears, or psychological conflicts they're unable to discuss directly. My role involves facilitating creative expression, interpreting symbolic content, and helping individuals understand how their artwork reflects internal emotional states. But over the past 2 weeks, I'd been discovering artwork in patient portfolios that I didn't remember collecting, created by individuals whose artistic abilities seemed to exceed their documented backgrounds and psychological conditions. The portrait of the institutional woman was filed in Portfolio 7, belonging to Marcus Reed, a patient with schizophrenia who'd never demonstrated visual art skills during our previous sessions. His artwork typically consisted of abstract color fields and simple geometric shapes that reflected his struggle with reality testing and cognitive organization. But this watercolor showed technical sophistication and emotional depth that suggested either remarkable hidden talent or creation by someone with professional artistic training. I checked the session notes for Portfolio 7, looking for documentation about when Marcus had created the portrait. My handwriting described a productive session where he'd worked on a landscape painting, showing improved focus and reduced paranoid ideation. No mention of the disturbing portrait that now occupied the top position in his folder. I found similar discrepancies throughout my patient portfolios. Advanced sculptures in the folder of a patient with severe cognitive impairment. Detailed pencil drawings created by someone whose motor skills were supposedly compromised by medication side effects. Oil paintings that demonstrated mastery of techniques none of my patients had studied. Most disturbing were the recurring images of a woman who looked like me, always depicted as a patient rather than a therapist. The artwork showed her in group therapy sessions, receiving medication from nurses, sitting alone in patient rooms, and participating in recreational activities. Each image was created in a different artistic style, suggesting multiple artists, but all shared the same subject: my face, my expressions, my mannerisms, rendered with intimate knowledge of my appearance and behavior. I pulled my own personnel file to verify my employment status and professional credentials. The documentation confirmed my position as art therapist, my educational background in psychology and fine arts, and my 4 years of employment at Millfield. But I found additional materials I didn't remember filing: treatment plans with my name listed as the patient rather than the therapist, psychiatric evaluations describing my condition and therapeutic needs, medication orders for antipsychotic drugs I wasn't taking. According to these documents, Catherine Wells had been admitted to Millfield 6 months ago following an acute psychotic break characterized by elaborate delusions about working as an art therapist. The treatment plan included occupational therapy, allowing me to conduct supervised art sessions with other patients, providing therapeutic value through connection to my imagined profession while gradually introducing reality testing. The patient file described my persistent belief that I was qualified to provide psychological treatment, my detailed knowledge of art therapy techniques, and my apparent satisfaction with conducting therapy sessions. Notes from my treating psychiatrist indicated that I'd developed an elaborate and internally consistent understanding of my role, creating detailed session documentation, and maintaining professional relationships with colleagues who were actually fellow patients or staff members participating in my therapeutic program. But the file raised questions about the nature of the artwork I'd been collecting. If I was a patient participating in occupational therapy, who had created the sophisticated paintings and sculptures I'd attributed to individuals with severe psychiatric conditions? The technical quality exceeded what most patients could produce, but it also surpassed my own artistic abilities as documented in my educational records. I examined the artwork more carefully, paying attention to artistic techniques, signature styles, and material choices. The painting showed consistent brushwork that suggested single authorship, despite being filed in different patient portfolios. The sculptures displayed identical approaches to form and texture. Even the drawing styles, though varied in subject matter, shared subtle similarities in line quality and compositional choices. I was looking at a comprehensive body of artwork created by one individual, someone with professional artistic training, extensive psychological knowledge, and intimate familiarity with psychiatric hospital operations. Someone who had access to art supplies, patient information, and detailed knowledge of therapeutic procedures. Someone who looked exactly like me and shared my name, creating self-portraits that depicted her as a patient rather than a therapist. The recreation room contained a large mirror mounted on the wall near the supply cabinets. I stood in front of it, studying my reflection while holding one of the portraits. The resemblance was exact. Same facial features, same hair color, same expression of confused recognition. But in the mirror, I wore professional clothing and maintained the confident posture of a hospital employee. In the portrait, the same face wore patient attire and displayed the vulnerable demeanor of someone receiving psychiatric treatment. I walked through the recreation room, observing other patients engaged in various activities. They worked on puzzles, played games, participated in group discussions led by staff members whose professional credentials I'd never questioned. But now I noticed details that disturbed me. The staff members wore clothing similar to mine, maintained similar professional demeanor, and demonstrated knowledge of therapeutic techniques that seemed inconsistent with their documented roles. Were they also patients participating in occupational therapy programs, allowed to maintain connections to their imagined professions while receiving treatment for psychological conditions? If so, what did that make the hospital itself? A facility where patients treated other patients in elaborate therapeutic role-playing scenarios that felt authentic and meaningful to everyone involved. I returned to my desk and opened a fresh sketchpad, preparing to create my own artwork for the first time since beginning work at Millfield. As I began drawing, I realized I was creating another self-portrait, a woman sitting in an art therapy session, surrounded by paintings that depicted her own face from multiple perspectives. But in this image, I couldn't determine whether she was the therapist conducting the session or the patient receiving treatment. The drawing developed with techniques I didn't remember learning, executed with confidence that exceeded my documented artistic abilities. My hand moved with practiced precision, creating subtle details and emotional depth that suggested extensive training and experience. As I worked, I understood that I was both the artist creating the portrait and the subject being portrayed, existing simultaneously as the person providing therapy and the individual receiving care. Some portraits never stop being painted. They just change which side of the canvas you're standing on. The patient's neurological examination revealed perfect coordination, intact reflexes, and cognitive function that contradicted the profound amnesia documented in her admission records. She followed complex instructions flawlessly, demonstrated sophisticated understanding of medical terminology, and displayed knowledge of neurological assessment procedures that exceeded what most healthcare professionals possess. Yet, according to her file, she remembered nothing from before a traumatic brain injury sustained 3 months ago. My name is Dr. Helen Rodriguez, and I specialize in traumatic brain injury rehabilitation at Riverside Psychiatric Hospital's Neurological Unit. The work requires precision, comprehensive cognitive assessments, detailed neurological examinations, and systematic evaluation of memory function to determine appropriate treatment interventions. Over 15 years of practice, I've developed expertise in distinguishing between organic brain damage and psychological trauma that manifests as neurological symptoms. The new patient, identified in her file as Jane Doe due to complete identity amnesia, had been transferred from emergency services following a motor vehicle accident. Brain imaging showed minor contusions consistent with mild traumatic brain injury, but her symptoms suggested severe cognitive impairment that seemed disproportionate to the documented physical damage. She claimed no memory of her identity, background, education, or experiences prior to awakening in the hospital 3 months ago. But during standardized neurological testing, she demonstrated abilities that challenged her amnesia diagnosis. "I'd like you to perform some simple coordination tasks," I said, beginning with standard motor function assessments. "Touch your nose with your index finger, then touch my finger." She executed the movement with perfect precision, but as she did so, I noticed she was simultaneously testing my coordination by observing how I demonstrated the task. When I touched my nose and extended my finger toward her, she evaluated my movement with the analytical attention of a medical professional assessing neurological function. "Now I'd like you to walk heel to toe in a straight line," I instructed, preparing to observe her balance and coordination. She performed the task flawlessly, but again I noticed she was watching my demonstration with clinical interest, noting my posture, balance, and gait pattern, as if conducting her own neurological assessment of my motor function. I proceeded with cognitive testing, memory evaluations, attention tasks, language assessments, and problem-solving exercises. She completed each test with remarkable accuracy, but throughout the process, she seemed to be administering identical evaluations of my performance. When I asked her to remember a series of words, she also monitored whether I could recall the list correctly. When I tested her mathematical abilities, she simultaneously evaluated my calculation skills. "You have extensive medical knowledge for someone with complete amnesia," I observed, noting her sophisticated understanding of the testing procedures. "I remember medical information clearly," she replied. "It's personal details that remain inaccessible. I can describe neurological anatomy, diagnostic procedures, treatment protocols, but I can't recall my name, my background, or my relationships." This pattern, preserved professional knowledge with complete personal amnesia, was unusual but not impossible in traumatic brain injury cases. Procedural memory often survives when episodic memory is damaged, but her medical knowledge seemed too current, too comprehensive, and too specifically focused on neurological assessment to represent general procedural learning. I reviewed her brain scans more carefully, comparing current images with those taken immediately after her accident. The pattern of injury was subtle but consistent with mild traumatic brain injury. However, I found additional scans in her file that I didn't remember ordering. Images taken periodically over the past 3 months, showing progressive healing, but also revealing anatomical details that seemed familiar in a way I couldn't identify. "I'd like to conduct some additional memory assessments," I said, pulling out more specialized testing materials. These evaluate different types of memory function. As I administered increasingly complex neuropsychological tests, I noticed the patient was conducting mirror evaluations of my performance. She presented memory challenges while I tested her recall, evaluated my attention while I assessed her focus, and examined my problem-solving abilities as I analyzed her cognitive function. The interaction felt like mutual neurological assessment, as if we were both patient and doctor simultaneously. I excused myself to review her medical file more thoroughly, looking for information about her educational background, professional experience, or any details that might explain her sophisticated medical knowledge. But the file contained information that disturbed me in ways I hadn't anticipated. According to the documentation, Jane Doe had been identified through comparison with missing person reports. Her actual name was Dr. Helen Rodriguez, neurologist at Riverside Psychiatric Hospital, reported missing following a motor vehicle accident 3 months ago. The file included my photograph, my employment records, my professional credentials, and detailed biographical information that matched my personal history exactly. But I was Dr. Helen Rodriguez. I'd worked continuously at Riverside for 15 years. I had clear memories of my education, training, career development, and daily work experiences. The file described someone who looked like me and shared my professional background, but who had been missing for 3 months while I maintained my regular work schedule and patient responsibilities. I pulled my own personnel file from the administrative offices, needing to verify my employment status and resolve the apparent identity confusion. But the file I found contained different information than I expected. According to hospital records, Dr. Helen Rodriguez had been on medical leave for 3 months following a traumatic brain injury sustained in a motor vehicle accident. The file included treatment notes documenting her care as a patient in the facility where she'd previously worked as a physician. The treatment notes described Dr. Rodriguez's persistent delusion that she continued working as a neurologist, her detailed knowledge of medical procedures she couldn't have legitimately accessed as a patient, and her apparent inability to recognize her changed status from physician to patient. The notes indicated she participated in occupational therapy activities related to her imagined profession, showing excellent cooperation and no signs of distress about her condition. I returned to the examination room where Jane Doe, or Dr. Helen Rodriguez, waited patiently for continued assessment. She looked at me with professional interest, as if evaluating my mental state and cognitive function through clinical observation. "I've been reviewing your file," I said, though I was no longer certain which of us was the patient and which was the doctor. "And what did you discover?" she asked, her tone suggesting she already knew the answer. "There seems to be some confusion about identity and professional status," I replied carefully. "The documentation suggests we may both be Dr. Helen Rodriguez." She nodded with the calm understanding of someone who'd already reached the same conclusion. Traumatic brain injury can create complex identity disturbances. In some cases, patients develop elaborate alter egos that feel completely authentic and internally consistent. "But which of us is the patient?" I asked. "Perhaps that's not the right question," she replied. "Perhaps we're both patients, both doctors, both experiencing different aspects of the same traumatic brain injury. The accident may have created a split in identity that manifests as two separate individuals sharing the same memories, knowledge, and professional background. The concept was neurologically impossible, but it explained our mirror assessments, our identical medical knowledge, and the contradictory documentation in our files. If a single traumatic brain injury had somehow created two versions of Dr. Helen Rodriguez, one who believed she was still working as a neurologist and one who accepted her status as a patient with amnesia, it would account for our parallel existence in the same medical facility. "The brain scans support this interpretation," she continued, pulling up imaging results on the examination room computer. "The injury pattern suggests damage to areas involved in self-recognition and identity integration. We may be experiencing different aspects of the same consciousness, each convinced of our own reality while unable to integrate into a unified identity." I studied the brain scans, noting damage patterns that could theoretically support such a complex neurological presentation. The images showed my brain, but they also belonged to the patient I'd been examining. We shared identical neurological anatomy, identical injury patterns, and identical cognitive profiles because we were, neurologically speaking, the same person. "What happens now?" I asked, though I suspected she would mirror the question back to me. "We continue the assessment," she replied, returning to her role as patient while I maintained my identity as the examining physician. "But we should both understand that the evaluation works in both directions. I'm studying your neurological function as thoroughly as you're examining mine." As we prepared to continue testing, I realized that successful treatment might require integrating our separate identities into a unified consciousness that could accept both the reality of being a neurologist and the truth of being a patient, recovering from traumatic brain injury. Until that integration occurred, we would continue existing as mirror images of each other, each convinced of our own authenticity while unable to recognize our fundamental unity. Some diagnoses never get completed. They just reveal which side of the brain injury you're observing from. The stain had grown 6 inches since last night, spreading across the linoleum in patterns that resembled words when viewed from certain angles. I'd applied industrial-strength cleaners, bleach solutions, and enzyme treatments designed to break down organic matter, but the dark mark continued expanding with geometric precision that suggested deliberate growth rather than natural spreading. "My name is James Patterson, and I've maintained the isolation wing at Westfield Psychiatric Hospital for 7 years. The work requires meticulous attention. Sanitize every surface, remove all potential hazards, ensure complete sterility in rooms that house patients with severe behavioral disturbances. Room 9 had been empty for 3 months, sealed pending renovation, but I maintained cleaning access for routine maintenance, and preparation for eventual patient assignment. The isolation wing occupies the hospital's oldest section, built in 1963, when psychiatric treatment involved extended confinement for individuals whose conditions couldn't be managed through medication or therapy. Modern treatment has made extended isolation unnecessary, but the rooms remain available for emergency situations requiring temporary patient separation from general population areas. Room 9 contained standard institutional furniture, metal bed, frame, small desk, single chair, toilet and sink combination. The floor was covered with commercial-grade linoleum designed to withstand frequent sanitization and resist staining from bodily fluids, medication spills, or cleaning chemicals. Nothing should be able to penetrate its surface or create permanent marks that resist professional cleaning products. But the stain defied both chemical treatment and logical explanation. I first noticed it 3 weeks ago, a small dark spot near the center of the room, roughly circular, about the size of a quarter. It appeared organic, possibly blood or other biological material, though no recent patient activity could account for its presence. I treated it with standard blood cleanup protocols, enzyme cleaners to break down proteins, bleach solution for disinfection, thorough rinsing with water. The stain remained unchanged. Over subsequent nights, I applied progressively stronger cleaning. Agents, industrial degreasers, acid-based stain removers, alkaline solutions designed to dissolve organic matter. I scrubbed with abrasive pads, used steam cleaning equipment, and even attempted to sand the affected area with fine-grade steel wool. Nothing reduced the stain's intensity or prevented its gradual expansion. By the second week, the mark had grown to the size of a dinner plate, developing irregular edges that created patterns resembling text when viewed from different positions. The writing appeared to be in English, though the letters were distorted and partially obscured by the stain's organic texture. I could make out fragments, "Help me," and "Can't leave," and what appeared to be a date from several years ago. I checked maintenance records for Room 9, looking for information about previous cleaning challenges or documented staining incidents. The logs showed routine maintenance for the past 3 years, with no reports of unusual cleaning problems or persistent stains. But I found entries in my own handwriting describing months of failed attempts to remove a stain that had been growing in size and complexity. According to my own documentation, I'd been battling this stain for over a year, trying numerous cleaning approaches and documenting its progressive expansion. The entries described patterns in the stain that resembled writing, attempts to photograph the markings for further analysis, and growing concern about the phenomenon's resistance to standard cleaning protocols. But I had no memory of writing these entries or experiencing the extended cleaning campaign they described. I reviewed hospital records for Room 9's patient history, searching for incidents that might explain the stain's origin. The room had housed various patients over the years, most with severe psychiatric conditions requiring isolation for safety reasons. But one case stood out. James Patterson, admitted 4 years ago following a psychotic break triggered by work-related stress. The patient file described a custodial worker who'd developed elaborate delusions about being responsible for cleaning hospital rooms, demonstrating detailed knowledge of maintenance procedures and institutional operations that suggested either professional experience or prolonged exposure to hospital environments. Treatment notes indicated he'd been allowed to perform supervised cleaning duties as occupational therapy, providing therapeutic value through connection to his imagined profession. According to the documentation, James Patterson had been assigned to clean Room 9 as part of his therapy program. The room had been configured as a controlled environment where he could engage in meaningful activities related to his delusions while receiving psychiatric treatment. Notes from his treating psychiatrist indicated excellent progress. He performed cleaning duties reliably, showed no signs of agitation or resistance, and seemed to derive satisfaction from maintaining institutional cleanliness standards. But the patient had died in Room 9 following complications related to his psychiatric medication. The incident report described a tragic but unavoidable outcome: adverse reaction to antipsychotic drugs, respiratory failure, unsuccessful resuscitation attempts. The body had remained in the room for several hours before being discovered during routine checks. I compared the date of James Patterson's death with my employment records at Westfield. According to personnel files, I'd begun working at the hospital 1 week after the patient's death, hired to fill a custodial position that had recently become vacant. My background check, references, and training documentation were all appropriate for the job responsibilities. But the coincidence troubled me. A patient with my name and occupation dying in the same room where I now battled a stain that resisted all cleaning attempts. I returned to room 9 with new cleaning supplies, determined to eliminate the stain through systematic application of every available chemical treatment. But as I worked, I noticed details about the room that I'd somehow missed during previous cleaning sessions. The bed frame showed signs of extended use, with impressions in the mattress that suggested long-term occupancy. The walls contained faint marks that might have been writing, though they were too faded to read clearly. Most disturbing was a small mirror mounted above the sink. As I cleaned around it, I noticed my reflection seemed different. My face appeared gaunt, my clothing looked like patient attire rather than maintenance uniforms, and my expression showed the vacant stare associated with severe psychiatric medication. I touched the mirror's surface and felt cold spreading through my fingers. The reflection didn't match my movements exactly. It seemed to lag slightly behind, as if showing someone similar, but not identical. In the reflection, I was the patient, James Patterson, performing cleaning duties as occupational therapy while receiving treatment for delusional beliefs about working as a hospital custodian. The stain continued spreading as I watched, forming more distinct letter patterns that spelled out phrases in my own handwriting. I died here and can't stop cleaning, and help me remember. The words appeared to be written from my perspective. As the patient, desperate messages left by someone who'd been trapped in room 9 and couldn't communicate his situation to staff members who saw only therapeutic progress. I realized I'd been cleaning the same stain for years, trapped in a routine that felt meaningful and necessary, but which actually represented my continuing death in room 9. The custodial work provided connection to my previous identity while I experienced prolonged dying from medication complications that had never been properly addressed. The stain wasn't something I could clean. It was the physical manifestation of my death, spreading across the floor as my consciousness gradually faded from medication-induced complications that the hospital staff had failed to recognize in time. But I continued cleaning because the routine was all that remained of my identity, and stopping the work would mean accepting the death that had occurred years ago in room 9. As long as I could maintain the custodial duties, some part of James Patterson survived, even if only as a ghost who couldn't recognize his own death. Some stains never come clean. They just show you which side of the mop you're supposed to be on. The delusion was remarkable in its sophistication and internal consistency. For 6 months, I'd been treating Thomas Anderson, a patient who maintained absolute conviction that he was a clinical psychologist conducting therapy with a delusional patient, me. During our sessions, he would slip into professional mode, asking probing questions about my psychological state, interpreting my responses through clinical frameworks, and expressing concern about my apparent inability to recognize my patient's status. My name is Dr. Sarah Chen, and I practice clinical psychology at Riverside Psychiatric Hospital, specializing in treatment-resistant delusional disorders. Thomas had been admitted following a psychotic break that manifested as elaborate occupational fantasies. He believed he held my exact position, claimed detailed knowledge of psychological theory and practice, and insisted that our therapeutic relationship existed in reverse of its actual structure. Such role reversal delusions are uncommon but not unprecedented in psychiatric practice. Patients sometimes develop grandiose beliefs about professional competency, particularly when their psychological education or exposure to mental health settings provides material for elaborate fantasy construction. Thomas demonstrated remarkable familiarity with clinical techniques, diagnostic criteria, and therapeutic procedures that suggested either previous exposure to psychology training or an unusually systematic delusion based on observed hospital operations. But during our Tuesday afternoon session, Thomas began describing details about my personal history that he couldn't possibly know. "I'm concerned about your progress," he said, assuming the posture and tone of a treating psychologist. "You've been avoiding discussion of the childhood trauma that triggered your initial decompensation." "Thomas, I'm your psychologist," I reminded him gently. "We've discussed this. "You're a patient here and I'm providing your treatment." "Sarah," he replied, using my first name with the familiar authority of a colleague. "Your dissociation from traumatic memories is preventing therapeutic breakthrough. Until you can acknowledge what happened when you were 12, you'll continue experiencing identity confusion about your role in this relationship." The reference to age 12 stopped me cold. I had experienced significant trauma at that age. A car accident that killed my younger brother while I survived with minor injuries. But I'd never disclosed this information to Thomas or included it in any documentation he could have accessed. The incident was known only to my personal therapist, my family, and the supervisors who'd reviewed my psychological fitness during graduate training. "How do you know about that?" I asked, maintaining professional composure while feeling disturbed by his impossible knowledge. "It's documented throughout your treatment file," Thomas replied, opening a notebook that I'd assumed contained his personal writings. 6 months of sessions, detailed therapy notes, assessment of your progress in processing survivor guilt and associated identity disturbance. He showed me pages of handwritten, clinical notes that appeared to document psychotherapy sessions between Dr. Thomas Anderson and patient Sarah Chen. The handwriting was professional, the observations were clinically sophisticated, and the content described therapeutic work addressing trauma I'd never discussed with anyone outside my personal treatment relationships. According to Thomas's notes, I'd been admitted following a psychotic break triggered by anniversary reaction to childhood trauma. My primary symptom was the delusion that I worked as a clinical psychologist, supported by detailed but fabricated knowledge of psychological theory and practice. Treatment involved allowing me to participate and supervise therapeutic activities, while gradually introducing reality testing and trauma processing. "This isn't possible," I said, reviewing documentation that seemed authentic but described events I hadn't experienced. "I am Dr. Sarah Chen. I have a doctoral degree in psychology, professional licenses, employment records, all part of the elaborate identity construction you've developed to avoid processing traumatic memories," Thomas interrupted, speaking with the patient authority of an experienced clinician. "It's actually quite remarkable. You've created an entire professional persona, complete with detailed knowledge of psychological principles and therapeutic techniques." I excused myself from the session and went directly to my supervisor's office, needing to verify my employment status and resolve the impossible situation Thomas had created. But Dr. Williams, my department supervisor, wasn't available. According to his secretary, Dr. Williams was conducting supervision with Dr. Thomas Anderson, reviewing his treatment of a challenging patient with elaborate occupational delusions. I waited in the hallway outside Dr. Williams' office, hearing muffled conversation through the closed door. When the supervision session ended, Thomas emerged, carrying case files and appearing comfortable and familiar with the administrative area. He nodded to me professionally as he passed. "Sarah, come in," Dr. Williams called. "How are you feeling today?" His tone was gentle, concerned, tinged with the careful kindness used when speaking with fragile patients rather than professional colleagues. He gestured for me to sit in the patient chair rather than the colleague chair I'd occupied during previous meetings. "I need to clarify something about my professional status," I said, remaining standing despite his invitation to sit. "Of course," Dr. Williams replied, consulting notes on his desk. "Dr. Anderson mentioned you've been having increased confusion about your role here. That's not uncommon during trauma processing. Identity issues often intensify before resolution occurs." Dr. Williams spoke about me as Thomas's patient, referring to my treatment progress and therapeutic breakthrough potential. He discussed medication adjustments, family therapy involvement, and discharge planning for my eventual return to outpatient care. According to his understanding, I was a patient who'd been receiving treatment from Dr. Thomas Anderson for 6 months. "I need to see my personnel file," I said, though the request felt less confident than it should have. Dr. Williams opened a filing cabinet and retrieved a folder labeled with my name. But instead of employment documentation, it contained patient records, admission forms, psychiatric evaluations, treatment plans, medication orders. The photograph showed my face, but I appeared confused and distressed, wearing patient clothing rather than professional attire. According to the file, Sarah Chen had been admitted following a severe dissociative episode triggered by anniversary reaction to childhood trauma. Initial symptoms included elaborate delusions about working as a clinical psychologist, detailed but fabricated knowledge of psychological theory, and persistent inability to recognize her patient's status. Treatment involved Dr. Thomas Anderson, who specialized in trauma-related identity disorders. The delusion is quite sophisticated, Dr. Williams continued, reading from Thomas's treatment notes. She's constructed an entire professional identity, complete with accurate knowledge of clinical procedures and administrative operations. Dr. Anderson has been allowing her to observe therapy sessions and participate in clinical discussions as a form of occupational therapy. I stared at documentation that seemed authentic but described experiences I couldn't reconcile with my memory of professional training, employment history, and daily work activities. Either the records were falsified or my perception of reality was fundamentally compromised in ways that made clinical practice impossible. Where did I acquire the psychological knowledge I demonstrate? I asked. Combination of sources, Dr. Williams replied. You audit college psychology courses during your lucid periods, read extensively in the hospital library, and participate in group therapy sessions where you observe various clinical approaches. Your intelligence is exceptional, which allows rapid assimilation of clinical concepts. The explanation was plausible but felt wrong. My knowledge of psychology extended beyond academic theory to practical clinical experience. Conducting assessments, managing therapeutic relationships, navigating complex diagnostic decisions. These skills seemed too sophisticated to develop through observation and self-study. But as I reviewed Thomas's treatment notes more carefully, I found descriptions of therapy sessions where I'd processed memories of my brother's death, explored survivor guilt that had shaped my adult relationships, and worked through identity confusion that manifested as professional grandiosity. The clinical work seemed authentic and therapeutically valuable, addressing psychological issues I recognized but had never consciously explored. Dr. Anderson has been very patient with your treatment, Dr. Williams continued. He understands that trauma-related delusions serve protective functions and can't be challenged directly without causing additional psychological harm. I returned to Thomas's office, or my office, depending on which version of reality was accurate, and found him preparing for our next session. He looked up with professional concern as I entered. How did the supervision go? He asked. Confusing, I replied, sitting in what might have been the patient chair or the therapist chair. I can't determine which of us is treating the other. That's progress, Thomas said, making notes in what might have been my file or his therapy planning materials. Recognizing the ambiguity is the first step toward integrating dissociated aspects of your identity. As we prepared to continue our work together, I realized that successful treatment might require accepting both versions of our relationship simultaneously. I was both the psychologist treating his delusions and the patient whose trauma had created elaborate professional fantasies. Until I could integrate these contradictory identities, we would continue existing in therapeutic limbo, each convinced of our own professional authenticity, while unable to determine who was helping whom recover from psychological disturbance. Some therapy never ends. It just changes which couch you're lying on. The call came through at exactly 3:47 a.m., like it had for the past 17 nights. Same time, same number, same voice, describing identical psychiatric crisis symptoms with identical terror and desperation. The caller was a woman experiencing acute paranoid delusions, convinced she worked at a psychiatric hospital that trapped people in repeating temporal cycles they couldn't escape. My name is Maria Santos, and I dispatch emergency psychiatric services for the Tri-County Crisis Intervention System. The communications center operates 24 hours daily, coordinating mobile crisis teams, hospital admissions, and emergency interventions for individuals experiencing severe psychological distress. I've handled thousands of crisis calls over 8 years of employment, but this recurring call defied every protocol and procedure I'd been trained to follow. Crisis services, this is Maria. How can I help you? My name is Maria Santos, the caller replied, her voice trembling with exhaustion and fear. I work as an emergency dispatcher at the Psychiatric Crisis Center, but something's wrong with the hospital where I'm employed. People get trapped here in loops that repeat the same experiences over and over. The caller's voice was familiar because it was mine. Same inflection, same speech patterns, same professional terminology modified by psychological distress. She was describing experiences identical to mine, but from the perspective of someone who believed she was trapped in repetitive cycles at her workplace. "Ma'am, I need you to tell me your location so we can send help," I replied, following standard crisis intervention protocols despite the impossible nature of the situation. "I'm at Riverside Psychiatric Hospital, 1247 Medical Center Drive," she responded, providing the address where I worked. "But the building isn't what it appears to be. Time moves differently here. The same events happen repeatedly, and no one remembers except the people who are trapped." I dispatched a mobile crisis team to the address she'd provided, though it was the same location where I sat answering her call. According to protocol, the team would arrive within 20 minutes to conduct psychiatric evaluation and determine appropriate intervention. But in 17 previous nights of identical calls, no crisis team had ever arrived, no incident reports had been filed, and no follow-up documentation existed. "Maria, can you describe the symptoms you're experiencing?" I asked, conducting standard psychiatric assessment while feeling increasingly disturbed by the conversation. "I receive the same crisis call every night at 3:47 a.m., she replied, describing my exact situation. "A woman calls reporting psychiatric symptoms, and I dispatch teams that never arrive. The call lasts exactly 13 minutes, ends when she says she's going to make the call herself, and then repeats the next night with identical details." Her description matched my experience precisely, but from the opposite perspective. She was the caller experiencing the loop, while I was the dispatcher trapped in the same repetitive cycle. We were both Maria Santos, both employed in psychiatric crisis services, both convinced that the other was the person needing emergency intervention. "What makes you think you're trapped in a time loop?" I asked, though I knew the answer because I'd asked the question 17 times before. "Because we're having this exact conversation for the 18th time," she replied. "You'll ask about my symptoms. I'll describe the recurring calls. You'll dispatch a team that won't arrive, and at 4 a.m. I'll realize that I need to make the call myself to break the cycle. I check the call logs on my computer, looking for records of previous identical calls. The system showed normal crisis call volume for the past month, with no pattern of recurring calls at 3:47 a.m., but as I scrolled through the entries, I found subtle inconsistencies, gaps in the timeline around 3:47 a.m. each night, missing call duration records, and dispatcher notes that seemed to describe the same incident repeated with slight variations. "The records don't show previous calls," I told her, though I was beginning to question the reliability of documentation that seemed to change based on my perspective. "They won't," she replied. "The loop resets official records each cycle, but some traces remain if you know where to look. Check your personal notes, your handwritten logs, anything that exists outside the electronic system." I opened my desk drawer where I kept unofficial notes and personal reminders about complex cases. Inside, I found detailed documentation about the recurring 3:47 a.m. calls, written in my own handwriting across multiple weeks. The notes described growing frustration with identical crisis calls that never resulted in successful intervention, concern about caller identity that seemed to match my own, and increasing anxiety about temporal anomalies affecting my work schedule. According to my handwritten records, I'd been experiencing the same call for over a month, documenting each repetition and noting subtle changes in the conversation. The caller always provided identical crisis symptoms, always described the same temporal loop, and always ended the call by announcing her intention to make the call herself. "You found your notes," she said, though I hadn't mentioned searching for them. "How do you know?" "Because I wrote them," she replied. "Every night after our call, I document the experience, hoping to remember the pattern and break the cycle. But the loop affects memory. Each night feels like the first time until you review the documentation." I studied my handwriting more carefully, noting variations in pen color, paper type, and writing style that suggested the notes had been created over an extended period. The entries described my growing awareness of the temporal anomaly, my attempts to break the pattern through different responses to the caller, and my increasing conviction that the caller was myself from a different temporal perspective. "What happens if I don't dispatch a crisis team?" I asked, though my training required response to all emergency calls. "You'll try that eventually," she replied. "You'll also try hanging up immediately, transferring the call to other dispatchers, and reporting the situation to supervisors. None of those approaches break the loop. They just create variations in the conversation." Then how do we stop the repetition? I think one of us has to accept that we're the same person experiencing different aspects of the same crisis, she said. The loop might be a psychiatric symptom, dissociation so severe that we exist as separate identities, one calling for help and one providing crisis services. The concept was psychologically plausible. Severe dissociative disorders could create alternate identities that seemed distinct, but shared the same underlying consciousness. If Maria Santos, the dispatcher, and Maria Santos, the caller, were both aspects of the same individual experiencing psychological crisis, it would explain our identical voices, knowledge, and perspectives. What kind of trauma would cause such severe dissociation? I asked, though I suspected she would describe experiences that matched my own suppressed memories. Work-related stress from handling psychiatric emergencies, she replied. Years of exposure to psychological crisis. Vicarious trauma from constant contact with human suffering. Gradual erosion of professional boundaries until we couldn't distinguish between helping others and needing help ourselves. Her explanation resonated with experiences I'd been avoiding. Increasing anxiety about work responsibilities, growing identification with callers in crisis, and blurring boundaries between professional duties and personal psychological needs. Crisis dispatch work involved constant exposure to psychological trauma, and I'd been showing signs of occupational burnout and secondary traumatic stress. The loop might be our mind's way of processing the realization that we need psychiatric help ourselves, she continued. Instead of seeking treatment directly, we've created this recursive crisis call, where we simultaneously provide and receive emergency services. As 4:00 a.m. approached, I realized she was preparing to end the call as she had for 17 previous nights. But this time I understood that ending the call meant accepting my need for psychiatric treatment rather than continuing to provide crisis services to others while avoiding my own psychological distress. I think I need to make the call, I said, though I was no longer certain which of us was speaking. Yes, she replied, but this time, when you call crisis services, let them help you instead of trying to dispatch help to yourself. The call ended at exactly 4:00 a.m., and I realized I was both the dispatcher who'd been receiving the calls and the person in crisis who needed to make one. The loop had been maintaining the illusion that I could provide my own psychiatric services instead of accepting help from colleagues who were trained to handle exactly the kind of occupational trauma I'd been experiencing. Some calls never end. They just change which side of the phone you answer them from. The 8th chair appeared in my group therapy circle on a Tuesday afternoon, positioned between Mrs. Henderson and Mr. Garcia with the same institutional precision as the 7 chairs I'd arranged for my regular patients. The additional furniture was identical, beige plastic, designed for easy sanitization, regulation height for therapeutic activities. But I had no memory of placing an 8th chair, and my session planning materials indicated only 7 participants. My name is Jennifer Walsh, and I conduct occupational therapy at Claremont Psychiatric Hospital, helping patients develop practical skills necessary for successful community reintegration. The afternoon group meets daily from 2 to 4 p.m., focusing on basic life activities, meal preparation, money management, social interaction, problem solving, and self-care routines. 7 patients attend regularly, each with documented progress goals and individualized treatment plans. But the 8th patient sitting in the additional chair challenged every aspect of my carefully structured program. She was a woman approximately my age, medium height. Brown hair pulled back practically, wearing standard patient attire. She participated in all group activities with mechanical precision, completing assigned tasks accurately, but without engagement or emotional investment. She never spoke during discussions, never asked questions about exercises, never interacted socially with other group members. Most disturbing was her apparent familiarity with occupational therapy procedures. She understood instructions before I finished giving them, anticipated activity sequences, and demonstrated knowledge of therapeutic goals that suggested professional training rather than patient education. When I introduced new exercises, she would begin working before I explained the process, completing tasks with efficiency that exceeded what most patients achieved after weeks of practice. Today we're going to work on budgeting skills, I announced to the group. distributing worksheets and play money for a simulated shopping exercise. The 8th patient immediately organized her materials, calculated expenses, and completed the budget worksheet while other patients were still reading the instructions. Her work was accurate, but lacked the personal touches that made similar exercises therapeutically meaningful. She chose generic items without preference, allocated funds without considering individual needs, and demonstrated competency without investment in the outcome. I checked my patient roster, looking for documentation about the 8th participant. According to official records, only 7 individuals were assigned to the afternoon occupational therapy group. But I found session notes in my own handwriting describing therapeutic activities involving 8 patients, including detailed observations about the quiet woman who participated without speaking. The notes spanned several weeks, documenting her consistent attendance, her mechanical completion of assignments, and my growing concern about her emotional detachment from therapeutic activities. According to my own documentation, she'd been attending group sessions regularly, though she appeared nowhere in official hospital records. "Jennifer, can you tell me about your progress with the budgeting exercise?" I asked, using the name I'd assigned to the 8th patient in my unofficial notes. She looked up with an expression of mild confusion, as if surprised to be addressed directly. After a moment, she replied in a voice that sounded remarkably similar to mine. "The exercise demonstrates competency and financial management skills necessary for independent living." Her response was technically accurate but emotionally flat, delivered with the clinical detachment of a professional observer rather than a patient engaged in therapeutic activity. She spoke about the exercise from an external perspective, analyzing its therapeutic value rather than experiencing its personal relevance. "How do you feel about managing money independently?" I asked, trying to engage her emotional investment in the skill development process. "Occupational therapy participants often experience anxiety about financial independence," she replied, continuing to speak in clinical terminology. "The exercise builds confidence through structured practice with controlled variables." She was describing occupational therapy techniques from a professional perspective, using language that suggested education in therapeutic methods. But patients don't typically analyze their own treatment from a clinical framework unless they have background in mental health services. After the group session ended, I reviewed personnel files for staff members who might match the 8th patient's appearance and mannerisms. I found my own employee record, but the photograph showed someone who looked like me wearing professional attire and maintaining confident posture. The 8th patient wore the same face but with the subdued demeanor of someone receiving psychiatric treatment. I pulled my personnel file more carefully, looking for employment history, professional credentials, and job performance evaluations. But I found treatment documentation instead: admission forms, psychiatric assessments, therapy goals, medication orders. According to the file, Jennifer Walsh had been admitted 3 months ago following a psychological breakdown triggered by work-related stress. The patient file described an occupational therapist who'd developed elaborate delusions about continuing to provide therapeutic services while actually receiving psychiatric treatment. Initial symptoms included detailed knowledge of rehabilitation procedures, persistent belief in her professional competency, and inability to recognize her changed status from therapist to patient. Treatment notes indicated that I'd been allowed to participate in occupational therapy groups as a therapeutic intervention, providing connection to my previous profession while gradually introducing reality testing. The program was considered successful. I demonstrated appropriate behavior, participated cooperatively in activities, and showed steady progress in processing the psychological issues that had led to my admission. But the notes raised disturbing questions about my perception of the group sessions. If I was a patient participating in occupational therapy, who was conducting the sessions I believed I was leading? I looked around the therapy room, noticing details I'd somehow missed during previous sessions. The room was arranged for patient activities rather than staff coordination. Educational materials were positioned for participant access, not instructor reference. The chair I'd been occupying was positioned within the therapy circle rather than in the leadership position outside the group. What I'd interpreted as professional oversight was actually therapeutic participation designed to support my recovery. Found the real occupational therapist's office, too, doors down from the room where I'd been conducting sessions. Through the window, I could see a woman approximately my age reviewing patient files and preparing materials for the next day's groups. She looked up as I approached, recognizing me with the familiar concern reserved for patients who'd wandered from designated areas. "Jennifer, how are you feeling today?" she asked gently. "You missed the end of group session." "I was conducting the group session," I replied, though the statement felt less certain than it should have. "You were participating in group," she corrected with patient kindness. "You've been making excellent progress in your occupational therapy goals. The simulation exercises help you maintain connection to your previous work while processing the stress that led to your hospitalization." I realized that the 8th patient I'd been observing was actually my own reflection in the therapeutic process, the part of myself that recognized I was receiving treatment rather than providing it. She attended sessions silently because she understood our true status as patients, while I maintained the illusion of professional competency through elaborate role-playing that felt authentic, but served therapeutic rather than occupational purposes. The mechanical precision with which she completed activities reflected my own professional training applied to patient exercises, while her emotional detachment represented the psychological protection necessary to accept treatment without losing connection to my previous identity. Some therapy never ends. It just changes which side of the exercise you're completing. The medication cart contained 17 fewer pills than my inventory logs indicated, despite perfect documentation of every administration throughout my 12 years of psychiatric nursing at Millbrook Hospital. Each discrepancy was small, 1 or 2 tablets, missing from bottles that should have contained dozens, but the pattern suggested systematic errors that violated every safety protocol I'd internalized through professional training and practice. My name is Patricia Newman, and I maintain absolute precision in medication administration on Ward 7, the chronic care unit housing patients with long-term psychiatric conditions requiring complex pharmacological management. The work demands meticulous attention, verify patient identity, confirm medication orders, calculate proper dosages, document administration times, and secure controlled substances according to federal regulations. But over the past 3 weeks, my medication management system had been revealing impossible discrepancies that challenged both my professional competency and my understanding of hospital operations. The first anomaly appeared on a Monday evening. Mrs. Rodriguez claimed I'd given her evening medications 30 minutes earlier than documented, though I had clear memory of administering her prescriptions at exactly 8 p.m. according to the standard schedule. When I checked my medication log, it showed 8 p.m. administration with my signature, but Mrs. Rodriguez insisted she'd received pills at 7:30 p.m. from a nurse who looked exactly like me. "That's not possible," I told her gently. "I'm the only nurse assigned to evening medications on this ward." "You gave me the white pills and the blue ones," she replied with certainty. "Same as always, but you seem different, quieter, more careful, like you were learning the routine instead of doing it automatically." I reviewed the ward staffing schedule to confirm that no other nurses had access to medication administration during my shift. According to hospital policy, only 1 nurse per unit could maintain controlled substance keys and documentation responsibilities. The schedule showed Patricia Newman assigned to evening medications Sunday through Thursday, with no overlap or substitution arrangements. By the end of the week, 5 patients had reported receiving medications from me at times that didn't match my documentation. Each described identical physical appearance, same height, same hair color, same uniform, but noted behavioral differences that suggested someone less experienced with the routine, despite apparent familiarity with individual patient needs. I began conducting medication counts more frequently, documenting inventory levels before and after each administration round. The discrepancies became more pronounced. Bottles showing fewer pills than prescribed, controlled substance logs indicating dispensations I didn't remember making, and patient charts containing my signatures for medications I was certain I hadn't distributed. "Patricia, we need to discuss some concerns about your medication management," my supervisor, Carol Jenkins, said during our weekly check-in meeting. "I've been documenting discrepancies," I replied, showing her my detailed inventory logs. "Pills are missing, but I can't account for the losses." Carol reviewed my documentation with the careful attention reserved for serious medication errors. "The pharmacy reports you've been withdrawing additional supplies beyond your normal requirements. Double orders for several patients, extra controlled substances, Backup medications that weren't requested. I haven't ordered extra supplies, I said. Though her statement suggested systematic over-ordering, that would explain the missing medications. My requisitions follow standard protocols. She pulled pharmacy records from the past month, showing order forms with my signature requesting additional medications for Ward 7 patients. The signatures looked authentic, the patient names were accurate, and the medication types matched current prescriptions. But I had no memory of submitting these additional orders. There's another issue, Carol continued. Several patients have mentioned receiving medications from you during shifts when you weren't scheduled to work. Day shift staff have reported seeing you in the medication room during hours when you should have been at home. The concept was impossible. I work Sunday through Thursday, 7 p.m. to 7 a.m., with no additional shifts or overtime assignments. My badge access records would show any unauthorized presence in medication storage areas, and security cameras monitored all controlled substance activities. But Carol showed me badge access logs indicating I'd entered the medication room during day shifts, weekend periods, and vacation days when I was supposedly off duty. The timestamp showed systematic presence during times I clearly remembered being away from the hospital. I think you should take some time off, Carol suggested with concern. Extended work stress can cause memory issues, confusion about scheduling, and problems with routine tasks that usually feel automatic. I accepted her recommendation for a week of administrative leave, but the break didn't resolve the medication discrepancies. If anything, they became more pronounced during my absence. Pharmacy records showed continued medication requisitions with my signature. Patients reported receiving pills from me during evening shifts, and staff members noted my presence in areas where I couldn't have been. When I returned to work, I found detailed medication logs in my handwriting documenting perfect administration records throughout the week I'd been on leave. The logs described interactions with patients, observations about their conditions, and professional assessments that demonstrated sophisticated understanding of their psychiatric needs. According to my own documentation, I'd worked every scheduled shift during my supposed vacation, maintaining normal medication routines while dealing with increasing confusion about my employment status and professional responsibilities. I approached Mrs. Rodriguez during my first shift back, needing to clarify her reports about receiving medications from me during my absence. You were here every night, she said with certainty. Same routine, same medications, same professional manner, though you seemed worried about something. Kept checking documentation more carefully than usual. Mrs. Rodriguez, I was on administrative leave last week. Another nurse must have covered my responsibilities. She looked at me with gentle concern. Patricia, you've been here every night for months. Same evening medication schedule, same careful attention to our needs. The only difference is that you've been asking questions about whether you're really working here or receiving treatment here. Her statement was nonsensical, but it aligned with other impossible reports I'd been receiving. If patients consistently reported my presence during times when I was absent, either they were experiencing shared delusions, or my absence wasn't as complete as I'd believed. I pulled my own employee file from Carol's office, needing to verify my employment status and resolve the contradictory information about my work schedule. But the file contained patient records instead of personnel documentation, admission forms, psychiatric evaluations, treatment plans, medication orders. According to the patient file, Patricia Newman had been admitted 6 months ago following a psychological breakdown related to work stress and professional burnout. Initial symptoms included elaborate delusions about working as a psychiatric nurse, detailed knowledge of medication administration procedures, and persistent belief in her professional competency despite patient status. Treatment notes indicated that I'd been allowed to participate in supervised medication distribution as occupational therapy, providing therapeutic value through connection to my previous profession while receiving psychiatric treatment for underlying psychological conditions. The program was considered highly successful. I demonstrated appropriate behavior, maintained accurate records, and showed no signs of distress about my psychiatric condition. But the notes raised disturbing questions about the nature of my medication administration activities. If I was a patient participating in occupational therapy, who were the other patients I'd been treating? Were they also individuals with medical backgrounds participating in therapeutic programs? Or was I experiencing elaborate hallucinations about professional responsibilities that didn't exist? I returned to Ward 7 and observed the evening medication routine from a different perspective. The patients I had been treating showed genuine improvement from their prescribed medications. Their conditions were stable, and their trust in my professional competency seemed authentic. But the ward itself felt different when viewed as a patient rather than a nurse, more like a controlled environment designed to support therapeutic activities than a traditional psychiatric care unit. Carol found me in the medication room, sitting quietly among the pills and charts that had defined my professional identity for what I'd believed was 12 years. "How are you feeling, Patricia?" she asked with the gentle concern reserved for patients rather than employees. "Confused," I replied. "I can't determine whether I'm a nurse treating patients or a patient participating in occupational therapy that involves medication distribution." "Both," Carol said simply. "You're a patient who was a psychiatric nurse before your breakdown. The occupational therapy allows you to maintain connection to your professional identity while processing the psychological issues that ended your career. The medications you've been distributing are real. The patients benefit from your care, and your work has genuine therapeutic value. But am I actually helping people, or am I experiencing delusions about professional competency?" "You're helping people," Carol confirmed. "But you're doing it as part of your own treatment rather than as an employee. The distinction might not matter to the patients who benefit from your care, but it's important for your recovery to understand your actual status here. Some medications never stop being distributed. They just change which side of the cart you're standing on." The competency evaluation should have been routine. Assess the defendant's understanding of criminal charges, evaluate her ability to assist in her own defense, and determine whether she was mentally competent to stand trial for murder. But as I reviewed the case file for Angela Morrison, accused of killing a hospital employee in what appeared to be an elaborate psychotic episode, I discovered details that challenged my professional understanding of forensic psychiatric assessment. My name is Dr. Angela Morrison, and I specialize in forensic psychiatry at Metropolitan State Hospital, conducting court-ordered evaluations for individuals whose mental health status affects their legal proceedings. Over 18 years of practice, I've assessed hundreds of defendants, prepared detailed competency reports, and testified in criminal cases involving psychiatric evidence. The work requires absolute objectivity and clinical precision. But this case presented an impossible situation. I was scheduled to evaluate a defendant who shared my name, my profession, and according to preliminary reports, my physical appearance. The defendant had been arrested following the death of Dr. Angela Morrison, a forensic psychiatrist found dead in her office at Metropolitan State Hospital under circumstances that suggested homicide. The accused, also named Angela Morrison, claimed she was the forensic psychiatrist and that the victim was actually a patient who'd been trapped in delusional beliefs about working as a doctor. According to police reports, the defendant had used detailed knowledge of hospital operations to access secure areas, approach the victim during what appeared to be a routine consultation, and commit murder while claiming she was freeing the victim from psychological imprisonment. The crime scene suggested intimate familiarity with psychiatric procedures and institutional layouts. I scheduled the competency evaluation for Thursday morning, though the arrangement felt surreal. How could I assess someone who claimed to be me while evaluating whether she understood charges related to murdering me? The administrative complexity alone violated standard forensic protocols. The defendant was brought to interview room C in restraints, accompanied by 2 security officers and a psychiatric nurse. She appeared calm, professional, and composed, exactly how I would expect to present during a forensic consultation. When she looked up at me, I was studying my own face, my own mannerisms, my own professional demeanor reflected in someone accused of murdering the person she claimed to be. "Dr. Morrison," she said, using my name with familiar authority. "I think there's been some confusion about this evaluation. I'm Dr. Angela Morrison," I replied carefully. "I'm here to conduct your competency assessment." "No," she said with patient certainty. "I'm Dr. Angela Morrison. I've been conducting competency evaluations at this facility for 18 years. You're a patient who's been experiencing elaborate delusions about working as a forensic psychiatrist." Her conviction was absolute, her demeanor was professional, and her knowledge of forensic procedures was sophisticated. She spoke with the clinical authority I'd developed through years of specialized training and practice. But she was accused of murdering the person she claimed to be, me. "Can you tell me about the charges against you?" I asked, following standard competency assessment protocols. "There are no valid charges," she replied with professional certainty. "I was attempting to help a patient who'd become dangerously trapped in occupational delusions. She believed she was a forensic psychiatrist qualified to conduct criminal evaluations, but she was actually a patient whose psychological condition had created elaborate professional fantasies. And this patient was you," she said directly. "Dr. Angela Morrison was a patient, not a doctor. I was trying to help her recognize reality and accept appropriate treatment, but she became violent when confronted with evidence of her actual status. I reviewed the case file more carefully, looking for information that might explain her detailed knowledge of my professional background and hospital operations, but the file contained information that disturbed me in ways I hadn't anticipated. According to investigative reports, the victim, Dr. Angela Morrison, had been found dead in an office that showed signs of extended patient habitation rather than professional use. Personal belongings suggested long-term residence, medication containers, indicated psychiatric treatment, and documentation scattered throughout the office appeared to be patient records rather than forensic evaluation materials. Security footage from the incident showed the defendant accessing the office with authorized credentials, speaking calmly with the victim for several minutes, and then engaging in what appeared to be a struggle. But the audio transcript revealed conversation consistent with a therapist attempting to convince a delusional patient to accept reality rather than continue living in elaborate professional fantasies. "The office where you were found contained extensive documentation about forensic psychiatric procedures," I said, noting her response to factual information about the crime scene. "Of course," she replied. "Occupational therapy for patients with professional delusions requires detailed materials about their imagined careers. The treatment involves gradually exposing them to evidence that their professional knowledge comes from observation, education, and wish fulfillment rather than actual employment." Her explanation was clinically sophisticated and aligned with legitimate therapeutic approaches to occupational delusions, but it suggested that everything I understood about my professional identity was actually evidence of elaborate psychological fantasies rather than authentic career achievement. "Show me your credentials," I said, needing to establish which of us possessed legitimate professional qualifications. She pulled a folder from her personal belongings, containing medical school transcripts, residency completion certificates, board certification documents, and employment records spanning 18 years at Metropolitan State Hospital. The credentials were comprehensive and appeared authentic, though they described the same educational and professional background I claimed as my own. I compared her documents with my own professional credentials, finding identical information: same medical school, same residency program, same board certification dates, same employment history. We both possessed complete documentation supporting our claims to be Dr. Angela Morrison, forensic psychiatrist with 18 years of experience in criminal competency evaluation. "One of us is experiencing identity delusions," I said, though I was no longer certain which person that might be. "Yes," she agreed. "The question is whether the delusion involves believing you're a patient or believing you're a doctor." I excused myself from the interview and went to the administrative offices, needing to verify my employment status and resolve the impossible situation. But the office where I'd expected to find my personnel file was occupied by someone else, another forensic psychiatrist who claimed to be covering my caseload during my extended absence. "Dr. Morrison has been on medical leave for 6 months," the substitute psychiatrist explained. "Psychological breakdown following work-related stress. She's been receiving treatment here as a patient while maintaining some involvement in forensic activities as occupational therapy. According to hospital records, Dr. Angela Morrison had been admitted as a patient following a severe dissociative episode that manifested as elaborate beliefs about continuing her professional duties. Treatment involved allowing her to participate in supervised forensic activities while processing the psychological issues that had ended her career. But the records also indicated that 2 patients named Angela Morrison had been receiving treatment simultaneously, one who believed she was a forensic psychiatrist conducting evaluations, and one who believed she was a patient trapped in delusional beliefs about medical practice. Both patients demonstrated extensive knowledge of psychiatric procedures, both maintained professional demeanor, and both insisted on their version of reality with absolute conviction. I returned to interview room C, where the defendant waited with patient calm. "I understand now," I said, sitting across from someone who might be my patient, my mirror image, or my alternate identity. "We're both patients, both doctors, both Angela Morrison, experiencing different aspects of the same psychological breakdown." "Possibly," she replied. "Or one of us successfully broke through the other's delusions and is now facing criminal charges for that therapeutic intervention. The murder might have been necessary to free one of us from a psychological prison. That felt completely real, but was actually elaborate occupational therapy designed to help process professional identity loss following psychiatric crisis. I realized that successful competency evaluation might require determining not just whether she understood the charges against her, but whether the charges themselves represented reality or continued psychological delusion. If we were both aspects of the same person experiencing dissociative identity disorder, then the murder might have been psychological integration rather than criminal violence. "What happens next?" I asked. "That depends on whether the court accepts my competency evaluation or yours," she replied, opening a folder containing detailed forensic assessment materials. "I've prepared a comprehensive report documenting your psychological condition, your delusional beliefs about professional competency, and my recommendation that you be found not competent to stand trial due to ongoing psychiatric symptoms." She handed me a document that appeared to be a professional forensic evaluation, written in the clinical style I'd developed over 18 years of practice, but the report assessed my mental health rather than hers, concluding that I was a patient experiencing elaborate occupational delusions who required continued psychiatric treatment rather than criminal prosecution. The evaluation was thorough, objective, and clinically sophisticated. It might have been the most accurate competency assessment I'd ever reviewed, even though it concluded that I was mentally incompetent to understand the professional standards by which my own competency should be evaluated. As I prepared to file the report that would determine which version of Angela Morrison would stand trial and which would continue receiving psychiatric treatment, I realized that the case had become forensic evaluation of my own professional identity, criminal defense of my own psychological state, and therapeutic intervention in my own dissociative crisis. Some evaluations never get completed. They just reveal which side of the competency hearing you belong on.